Namaskar and very good morning to the esteemed panel of eminent guests, Honorable Governor, and speakers whom we are fortunate to have today, and our dear viewers on this Ayushman Bharat Conclave 3rd edition, which we are doing in support with Niti Aayog. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, India's foremost institution for health awareness, advocacy, and behavior change. And I warmly welcome all of you for this important program. Before we start, and we have our chief guest of this program, Honorable Governor of Telangana and Lieutenant Governor of Pondicherry, Dr. Tamilsai Soundararajan. And before we begin that, I would request our speakers and guests to stand for the national anthem. Thank you, everyone. And Honorable Governor, Madam, may we proceed with today's program? So today is an important day for all of us at the ISW Council as an institution that has continually striving to become a staunch advocate of a healthy and productive life for all our citizens. This day propels and inspires us to reaffirm our vows and recommit ourselves for the ultimate goal of getting universal health coverage in our country. This conclave was initiated to advocate for building a healthcare system that truly helps people be Ayushman or long living, and has become a key forum to evaluate the success of the grand vision of the Mega Ayushman Bharat mission. And indeed, we have come a long way, but we still have a long way to go. September 27, 2018 proved to be a red letter day for every Indian in every possible way. The steadfast campaign to strengthen the health facilities of this country that goes back to decades saw a beacon of hope as the Honorable Prime Minister Narendra Modi launched the ambitious Ayushman Bharat, the world's largest government-funded healthcare scheme, aimed at benefiting millions of marginalized people of our country. And most of us are already aware that India witnesses a higher rate of communicable and non-communicable diseases, and tens of thousands of Indians bear the terrible socioeconomic consequences while paying for hospitalization. It is also estimated that millions of Indians are pushed to poverty due to astronomical pocket expenses. And in this backdrop of such complex reality, the Ayushman Bharat scheme, which is also called the Prime Minister Jan Arogya Yojana PMJ, came into existence. And in just 3 years of its existence, this scheme has immensely contributed to addressing the mounting challenge of equitable healthcare access for poor of this country. And not only the Ayushman Bharat scheme facilitated approximately 2.2 crore hospital admissions worth more than 26,000 crore through a network of nearly 24,000 impaneled hospitals across the country. And most importantly, during this time of pandemic, over 8.3 lakh COVID-19 cases were also treated under the Ayushman Bharat scheme over the last almost 22 months. And this day of universal health coverage is important day to celebrate these achievements which we have made in this mega scheme, which actually helped we Indian to move closer to the larger dream of having a universal health coverage. And just like the past two successful editions of Ayushman Bharat Conclave, this third edition of this e-conclave, which we are hosting with support from Niti Aayog, is also our endeavor to bring to the fore the nation's commitment to helping the underprivileged by assisting them to get benefits of Ayushman Bharat scheme. And while we will be wholeheartedly celebrating the stride of this mission so far, experts today who will be joining would also help us understand the gaps that still keep many away from its benefits. And more importantly, how this can cover everyone, everywhere, realizing the actual dream of an equitable, accessible, and empathetic universal coverage, health coverage for our nation that is home to 1/6 of humanity. So before we invite our esteemed guest of this session, let's have a quick view on the journey so far of Ayushman Bharat Conclave.
India, the fastest growing nation on the earth, faces the fastest growing health challenges with over 1.3 billion lives at stake. In the wake of a swelling disease burden and severely compromised health ecosystem, it was imperative that everyone gets talking about good health. Aiming to create continuous advocacy for health, the right to good air, good food, good water, and good healthcare, as well as many other aspects of holistic health. Policymakers, various industry captains, community leaders, innovators, health experts, celebrities, and influencers deliberate upon the many challenges and opportunities of improving health outcomes in India. The Integrated Health and Well-being Council initiatives have become the platform of choice to launch various impactful programs that drive the country towards better health.
The purpose of Ayushman Bharat Conclave was to bring together all the stakeholders of Ayushman Bharat.
Well, it's a remarkable ambition and achievement.
It will change the face of the health sector. It has put health in the center stage and it is going to be a game changer.
It is better to come to a doctor and get his test done in wellness rather than illness.
Pulling together stakeholders who are not yet visible in the current frame.
One very simple message about Ayushman Bharat. If it has to be made as a Jan Andolan, there's a very, very big role of media which has to play because you're the guys who reach to the last mile.
Build larger consensus and drive sustained advocacy to achieve universal health cover for all Indians.
Thank you so much. So now I would invite our first eminent guest of this session, Dr. Professor Y.K. Gupta, the President of All India Institute of Medical Sciences, AIIMS, Bhopal and Jammu. He is the Principal Advisor, Projects for Department of Biotechnology, Government of India, and former Dean of Academics and Head of Department of Pharmacology, AIIMS, in New Delhi, where he established the Department of Clinical Pharmacology as well. So, Dr. Y.K. Gupta, please help us understand your thoughts so far about the achievements of Ayushman Bharat as a mission and how we can take that forward to actually reach to the dream of getting a universal health coverage. Sir, over to you.
Thank you, Kamalji. And before I say anything, I must congratulate you and Niti Ayog for organizing this wonderful session on one of the world's unique and largest healthcare mission, which under the leadership of our Prime Minister Narayan Modi has been started in India. Why it is unique? India is the second largest population of the world. The economic status is not as good as
they are asking him to talk.
population of the public, largely in rural area or even in urban area, is not able to afford the treatment, particularly when it is required for some long-term disease, complicated disease, cancer, or maybe ENT replacement. Dr. Narayan is sitting here, or it may be something which requires a sophisticated instrumentation or investigation, requiring cost, hospitalization, and expensive medicine. They have been in good access to primary health care. But if it requires a specialist, the question is how they can afford. And that was the major concern and was addressed and is addressed under this policy. This is the largest government insurance policy in the world, where all the lower income group, I would say the people who are not able to afford are covered under this insurance policy. And then they are now getting the entire benefit of getting the highest of the possible care in India, whether at All India Institute of Medical Sciences or in corporate hospital, private hospitals, or district hospitals, and the entire coverage of their healthcare is covered under this. We are specifically instructing our authorities and doctors at All India Institute of Medical Sciences to give utmost priority to all those who have the Ayushman Bharat card. And this is one of the success story. Now, if I talk to 100 people in Bhopal or in Jammu or in Delhi, particularly the rickshaw puller or the low income group, 80% of them are aware of this, and that itself speaks success. Now, what are the challenges here? Challenges are still those people who are not fully aware of that there is a facility. People are still, many people may think that this is a lot of bureaucratic process involved in that, making card, going to that, and the hospitals may refuse and things like that. So these type of perception need to go. And that is why you're educating just like this symposium will help. The second thing is the people perception that under Ayushman Bharat, the quality of treatment may not be the best because the charges are limited. The institutions or the private sector is charging within the prescribed limit, which they think is not profitable. Now, this perception must go, and we have to ensure that the quality of the treatment, the quality of the investigation, the quality of medicine, and the quality of expertise which is provided under Ayushman Bharat is of the same best quality as it is given under any other care. So once this perception under the public is taken care of, I think we will get full advantage of this. Important thing is also that Ayushman Bharat has given a list of procedures, list of treatment, and their affordable, their charges, prescribed charges. And these charges have been decided in a consultative manner with involving all the stakeholders and are very, very reasonable, which also allows a reasonable margin of profit to the institution, but it does not allow profiteering. And that is what is important. And that's why sometimes a feedback, a dynamic mechanism, which is already working, is to be there. तो इसमें बहुत जरूरी है कि हम क्वालिटी ऑफ मेडिसिन को इंश्योर करें और ये पब्लिक को भी बताएं. दूसरी चीज क्वालिटी ऑफ इन्वेस्टिगेशन. तीसरा, the public perception will go when they will see that so many people are benefited. Now, as on date, more than 2.4 crores have already been benefited, and each family communicate to 10 families. So some states, because it was a voluntary scheme, some states initially showed some reservation. But now more and more states are thinking to merge with this mainstream of Ayushman Bharat. So I am very optimistic that this scheme will survive, will persist, and will cover all the population in India, which sometimes is hesitant to go to the private big hospitals and see. वो कहता है अरे यार ये तो बड़ा big hospital है, ये तो सिर्फ बड़े लोगों के लिए, ये तो हमारा एक्सेस से बाहर है. Now they can also see ये hospital हमारे लिए भी हो सकता है because of PMJ or because of Ayushman Bharat, and I can also afford, I can also get the same type of treatment which a Mercedes car owner will get.
Thank you so much, sir. That's a very, very encouraging words from you for, the potential, and then the great support which every human and every Indian actually can expect from this great scheme, which I'm sure is expanding its coverage much faster, and the government of India is committed for that. We also have with us Dr. Professor Nitin M. Nagarkar. He's a noted ENT specialist, and he's currently the director of AIIMS Raipur, a position he's holding since his appointment in 2018, and a stalwart in medical research. Dr. Nagarkar specializes in head and neck oncology, neuro-otology, and other neuropsychiatric aspects. So, Dr. Nagarkar,
Nitin, I would just add also, Kamal, I will also add that Dr. Nitin is also holding charge of Director AIIMS Bhopal.
So we're together on board.
So that's why we are together. Yeah.
So the director of AIIMS Raipur as well as director of AIIMS Bhopal.
Yes.
Sir, over to you, please.
Thank you very much, Kamalji, and Honorable Governor Madam, respected Professor Y.K. Gupta sir. We have Dr. Madan Gopal from the Niti Aayog, Dr. J.L. Meena sir, Dr. Hima Diwakar, and we've got so many other leading people here on board today online. Thank you very much, Kamal Narayan ji, for giving us this opportunity. I think sir has really set the tone by mentioning about how this particular program of the Government of India has been a game changer. I would just add certain things like what has been our experience sir, at Raipur or Bhopal. For the last almost 3 years, we have got this the Ayushman Bharat scheme working in both these institutions, and an excellent response from the patients. I do agree that there are many patients from the hinterland who are not aware, but I've seen that in the last almost 1 or 2 years, many and more people have become aware of it, and they are coming and seeking treatment. And especially so for the surgical packages, it's very important that for those patients, because they're unable to get their surgeries done outside, and always the package, whether it is investigations, whether it's a surgical treatment, and then the medications during the course of their admission, I think all of that is very well taken care of. And there is a great faith in these institutions, especially in the large government hospitals in our country, especially for institutions like AIIMS. And we are happy that we can cater to a much larger population now who was possibly hesitant to come, whether they would be able to have the financial resources and meet the out-of-pocket expenses, because each and everything is provided to the patients when they come to us for the surgical packages. So I think it's a great scheme, and I think we'll be keep on learning as we have more and more experience. But I'm sure that as thousands of patients have benefited in our institution, it adds up, and I'm sure that millions would get the benefit in our country. And I think it's a great step forward by our Honorable Prime Minister, sir. And I think there'll be a lot of learning experiences, not only for our country, I think that even at the global level, as to how to implement this particular scheme. So thank you very much, because we have the next meeting just ready. But I'm sure that I think we had great discussions with all of you. Thank you.
Thank you so much, Dr. Nitin, for your very encouraging words. And I'm sure, as you have highlighted, this scheme is reaching to a lot of those underprivileged people, and helping them actually when they are in dire need of it. Now we'll go to our chief guest, Dr. Tamilsai Soundararajan, Honorable Governor of Telangana and Lieutenant Governor of Pondicherry. Dr. Soundararajan is a doctor by profession and worked as an assistant professor at Ramchandran Medical College in Chennai for 5 years, both as a medical professional and during her long political career. She has been a staunch advocate of gender equality and women health and empowerment. She was conferred with International Rising Star of the Year 2018 award by Multi-Ethnic Advisory Task Force in the United States. And she Doordarshan aired her weekly program on women health by the name of Magalir Panchayat for more than 5 years. And that shows that Dr. Soundararajan's commitment towards ensuring health awareness and access to the people of our country. So over to you, Honorable Madam Governor. We would be, very keen to hear from you that how you see, as a healthcare professional also, that this mega scheme of Ayushman Bharat is actually helping all of us, all of Indians, to get that much, desired and much required universal health coverage as we move forward.
A very special good morning to each and everyone. Mr. Kamal Narayan, CEO Integrated Health and Wellbeing Council, and thank you for your good introduction, not only of mine, of the Ayushman Bharat, which I respect, the greatest insurance scheme as a doctor. I laud this program, and from the bottom of my heart, I thank our Honorable Prime Minister for implementing this insurance scheme, the world's largest insurance scheme, because as doctors, I share the views with other doctors, professionals also. So in each and every day, we have seen patients dying for want of few rupees, for medicines, and for want of surgeries, for want of tertiary care. And really, as a medical professional and a common citizen, one among the common citizen, I laud this program. So I'm immensely happy to participate in this program. Mr. A. Sridhar, Managing Director of Limited and President, and Dr. Amrish Mittal, Member, Governing Board, National Health Authority, Chairman and Head of Endocrinology and Diabetes, Max Healthcare, Dr. Hema Divakar, Consultant, Obstetrics and Gynecology and Medical Director, Divakar Specialty Hospital, and my respects to Professor Nitin A. Nagarkar, Director, All India Institute of Medical Science, Raipur, Professor Y.K. Gupta, President, AIMS, Bhopal, Dr. Sunil Kumar, Director General, Health Service, Ministry of Health and Family Welfare, Government of India, and all the dignitaries have joined this webinar. It gives me immense pleasure to be with you all at the inauguration of this prestigious 3rd edition of the Conclave on Ayushman Bharat and Digital Health Mission. I appreciate and congratulate the Integrated Health and Wellbeing Council for this initiative with the support of Niti Aayog. I am extremely delighted and honored to speak about the universal health coverage that was conceived with singular goal, together for all and development for all. In a country like India, with its homogeneous population of 1.3 billion people, We all, for a very long time, were waiting for a comprehensive health protection scheme that would serve all poor and needy. Ayushman Bharat is a universal health protection scheme extended to all the sections of the people across the country. A health protection scheme that does not differentiate between people based on religion, caste, and location. The Ayushman Bharat, which was launched in 2018 by our Honorable Prime Minister Sri Narendra Modi ji, has contributed significantly in addressing the mounting challenge of equitable access to inpatient healthcare for the poor in India. This is especially challenging as the ratio between the rural and the urban population is 70% and 30% respectively, and which is facing a dual health problem of the communicable and non-communicable diseases, and where millions get pushed into poverty due to catastrophe out of pocket medical expense annually. In fact, the Ayushman Bharat scheme, since its inception, aimed to publicly fund the healthcare. The major healthcare scheme represented rather unique opportunity to institutions, quality healthcare at the point of service for the most marginalized Indians, therefore improving the health of the population and drastically reducing or eliminating medical related impoverishment. I should say here the foresight of our Honorable Prime Minister, because the pandemic, the Government of India introduced this scheme 3 years back, and for the past 2 years, the whole world is facing an unique situation of pandemic. So in this pandemic situation, the scheme of Ayushman Bharat supported our citizens in a tremendous way that I should contribute the Government of India for this flagship program. The ambitious mission also aimed to develop the capacities of primary, secondary, and tertiary healthcare system, strengthening the existing national institutions and create more such institutions to cater to the detection and cure of new and emerging diseases. It must also be noted that at a time when India is still battling the COVID-19 pandemic, the Ayushman Bharat, as I said, provided medical relief to lakhs of Indians in just 2 years. It is worth mentioning that the Ayushman Bharat is considered as the world's largest healthcare assurance scheme. Insurance scheme, that is assurance scheme in the world, that will benefit an approximate 50 crore population that form the 40% of the bottom population of India. The Ayushman Bharat Yojana is also being considered as one of the major flagship program of the Government of India since independence. It is enabling the creation of digital health ecosystem across the country, and the establishment of health and wellness centers is transforming the accessibility of quality healthcare at the grassroots level. I want to mention here, because it is not only the treatment, the wellness centers is transforming the accessibility, because it has created awareness among the public about the healthcare. It is interesting to note that the public hospitals are reimbursed for the healthcare services at par with private hospitals. This is the unique feature of the scheme that also aims at strengthening the public care assurance across the country. If we shed light at Telangana, a state over 3.5 crore population, the state government under the leadership of Chandrasekhar Rao recently signed a memorandum of understanding with National Health Authority for the implementation of Ayushman Bharat scheme. Why I am mentioning? First, the state government was hesitant to join the scheme, but when it was explained to the state government, the major achievement of this scheme, I'm happy that the state government has shown keen interest and is willing to join Ayushman Bharat, and I have also been pursuing the same. It is also worth noting that the convergence of Ayushman Bharat and Arogya Shri, the Telangana government ensures the treatment of COVID-19 patients through the joint initiative. And I should say that I am the Lieutenant Governor of Puducherry with additional charges, and I am very proud to say that the targeted family for Ayushman Bharat in Puducherry is 1,76,120, and I'm happy to note that we have enrolled 1,54,707 families, and that has covered 87.85. And I'm very proud to say that 87% of the population is having the health card, for that which have been appreciated and awarded we got the appreciation from the Central Health Ministry and from the Ayushman Bharat institution, so that because we motivated and we initiated, and I laud our Honorable Prime Minister, when this Garib Kalyan Yojana was introduced, we had the counters in all the places, and we explained to the people about the Ayushman Bharat, and the Puducherry, the people accepted it, and I'm very proud that Puducherry has achieved 87.85% of enrollment of the Ayushman Bharat, which is very helpful in the treatment of pandemic, and it is also helpful to improve the infrastructure, a blessing in disguise, to improve the infrastructure of the hospitals by the aid from the Ayushman Bharat. India emerging as the vaccine capital of the India, and I am very proud as an Indian, as a doctor, as a citizen. I have taken the vaccine which is produced from my country, we have crossed more than 130 crore doses, and I'm really very proud of our country, because as medical students, we were longing for the vaccinations and immunizations which were imported from other countries, and I'm very happy that more than 100 countries we are exporting the vaccines, and I'm very proud that I, as an Indian, I have taken vaccine which is produced in my country. It is known, our India is known as the pharma manufacturing hub of the world. Soon it will emerge as one of the top destinations for the medical tourism in the world. The government, under the visionary leadership of our Honorable Prime Minister Shri Narendra Modi ji, has supplied vaccines to more than 90 to 100 countries. Our pharma sector is supplying medicines to more than 200 countries. I take this opportunity to sincerely thank the Council of organizing for the third edition of the Ayushman Bharat Conclave, to throw light once again on the Ayushman Bharat scheme that offers a holistic treatment, universal healthcare for millions of marginalized families in this country. As we look to enter a post-pandemic world in the coming days, I am extremely hopeful that the respected members and the dignitaries will take note on today's discussions and formulate policies to make the role more integral to the growth and success of this game-changing initiative that aspires to build a healthcare superhighway. The legendary Saint Thiruvalluvar pointed out in his immortal Tirukural, Piniyinmai, Selvam, Vilayinmai, Emam, Aniyanva, Nati Vaindu. A country's jewels are these five: unfailing health, fertility, and joy, a sure defense and wealth. With unveiling the Ayushman Bharat, the most precious jewel, that is unfailing health, has been achieved for our country. Jai Hind, Jai Telangana, Jai Puducherry.
Thank you so much, Honorable Governor, for your very inspiring and encouraging address. And we really, feel that the way you see this important scheme as a game changer, which has actually brought a really incredible support for millions of poor people in our country, and your personal involvement in ensuring that the people of Puducherry and almost 70-80% of them get covered, and they get their Ayushman Bharat card. And also it's very kind of heartening to know that the government of Telangana has also I think we all should, when it comes to the health of the people, we should all put our political differences aside and work together as a team to help the people, because health and life is something which has to be put on the top priority for everyone. Thank you so much for your being part of this and encouraging us. I would now request Dr. Hema Divakar, the CEO of Asian Research and Training Institute for Skill Transfer, artist, and a very ardent health champion, and also advisory board member of ISW Council, to kind of place a vote of thanks for Honorable Governor for her address, and then we will move ahead with the program as the Honorable Governor depart with the national anthem. Over to you, Dr. Divakar.
Thank you, Kamal. Our chief guest for the day, Honorable and respected Dr. Tamilsai Soundararajan. Vanakkam. On behalf of the ISW Council and the distinguished participants in the panels, not only for the inaugural event, but through the day, Ayushman Bhava. And on behalf of everybody, they would have said the Vanakkam very differently, Namaskar, Namaste, Namaskara, etc. And this multifaceted language barrier is also now being broken on the digital platform, with the multiple options of addressing each and every citizen of our country in their own native language, with the rich resources that we have. I must say, madam, that you are a doctor, so you work with your heart, being kind and compassionate, and wanting to make sure that the healthcare reaches every nook and corner of the country. But in your position as the governor and many other prestigious positions that you have held, you also work with your head. And therefore, the strong implementation policies, I'm so delighted and so proud to see the Puducherry blueprint, where almost everybody in that geography is enrolled into the Ayushman Bharat scheme. And we stand today in an attitude of gratitude to our Honorable Prime Minister, who recognized that India is a country which leapfrogs. Our little villages oftentimes do not have the citizens with the footwear or the bathroom, but they have a mobile phone. From there came in the idea that universal healthcare, if we are talking, and if we have to reach everywhere, then going digital is the only way. And when we speak about access, yes, we can go digitally through the access, but madam, as you said, it does more than just the access, because as how it has been alluded to, the quality of care. It gives access to the people, it gives access to the healthcare providers. So the access to information, access to their rights, their awareness is also through digital, getting enhanced synergistically with platforms such as ISW Council as well, and access to the quality care, where we strengthen the supply of the quality of healthcare by the capacity building, again through the digital platforms, so that the demand and supply match. So through the day, the distinguished panel will place their thoughts reflecting on what has happened so far and how we should take this agenda ahead. So looking back with pride and moving forward with courage and confidence is the message that you have given us. And we truly, truly appreciate your presence and participation. And may you always have the support of everybody concerned to move the needle of the healthcare ecosystem far ahead than what it is, because we do believe that women's health is nation's wealth. And with women like you in positions of power, it is the power to give. Give your best to all of us, and we are all there moving together in synergy because we believe that together we can. Thank you very much once again on behalf of, he has almost been christened as Dr. Kamal Narayan. So Kamal Narayan ji, Madan Gopal ji, Meena ji, and the rest of the faculty who will be joining us soon. Once again, Dr. Tamilsai Soundararajan. In platforms with Dr. Usha Sriram, who's an endocrinologist, I had the courage to speak in Tamil in front of her. And when I heard her Tamil, I said, this is not sounding like my Tamil, because it is a, now she quoted the verse which really means a lot, and the insights that she has given us will always be cherished. Welcome again, and thank you very much.
Thank you so much, Dr. Divakar, for this very, I think encouraging again this vote of thank. And now I would request all our guests to please stand up for the national anthem as the Honorable Governor departs for her further proceedings and engagement. Once again, thank you. Thanks to the Honorable Governor for sparing her, valuable time to address this inaugural session of Ayushman Bharat. Now we would be going with our the further part of this inaugural session, which is a panel discussion with our esteemed guests and speakers who have joined us today from Niti Aayog as well as the National Health Authority. So let me introduce our speakers for this panel. First, we have Dr. Jeetulal Meena. Dr. Meena is presently the Division Head of Service Provider Engagement, National Health Authority, and with 24,000 hospitals being on the panel of Ayushman Bharat, we can all understand the kind of effort and dedication Dr. Meena must have put to ensure that we have a big pool of hospitals, both government and private hospitals across the country, to help this scheme and its benefit reach to the people of India. Dr. Meena plays a key role in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana in hospital empanelment, a health benefit package, quality assurance, and also standards treatment guidelines for the scheme. So welcome, Dr. Meena. We have Dr. Madan Gopal, K. Madan Gopal, who is a renowned health professional and has been working on issues related to health systems, reforms, and strengthening this system in our country for more than 28 years. He is a part of Niti Aayog, and during his career span, he has held many leadership positions and demanding role, including one of the key team member behind the implementation of the world's largest health insurance scheme called Rashtriya Swasthya Bima Yojana, which was a predecessor of, in a manner, the Ayushman Bharat, which we see a much grander scheme and the mission which we are celebrating today. We have with us Dr. Hema Divakar, the CEO and Chairman of Asian Research and Training Institute for Skill Transfer, artist for her, and also advisory board member of ISW Council. An ardent advocate of women health, she is working with the vision to improve the healthcare services ecosystem for the welfare of women and children of our country. Dr. Diwakar has also been instrumental in our mega mission of Women Health Sapath 1000 Days and has played a pivotal role in improving the women health outcomes of our country. So welcome all our esteemed guests for this panel. So let me begin with Dr. K. Madan Gopal on this panel. Dr. Gopal, you from the Niti Aayog point of view, as a think tank of the government of India, and I'm sure it played a very critical role in the formation of Ayushman Bharat mission and a project. How do you see after almost 3 years of Ayushman Bharat scheme being in the play? How much we have moved towards that dream of, and you have been a critical part of the previous scheme also. How do you see that Ayushman Bharat had actually helped us move towards that vision of universal health coverage? Sir, you are on mute.
Okay, thank you. Kamalji, that's very interesting questions, because if you look at the precursor of Ayushman Bharat, when this scheme started in 2008-9, during that time also, because universal health coverage as defined, is an important element of having a protection against financial catastrophe. Whereas we are moving in that direction, and one of the objectives which was not there in the precursor was the out-of-pocket expenses, reduction of out-of-pocket expenses, and one of the objective of Ayushman Bharat is reduction in out-of-pocket expenses. If you look at the out-of-pocket expenses in the country before the launch of Ayushman Bharat, it was around 70%, and majority of the things coming from diagnostics and the drugs to spend on treatment. If you look at the figures of the burden of disease, the secondary care is also a very important aspect of the care provisioning. While the government is spending, if you look at the 11th Finance Commission report and the expert group there, they have envisaged that for providing care, we will requiring around 1,500. I'm talking about during the 11th Finance thing, a high-level expert group was there, which has given us the report. They have told that around 1,500 rupees would be required for providing health care. That was the factor based on the assumption that what is the current spend of healthcare on healthcare vis-a-vis GDP, and 1,500 was coming, and 1,100 was envisaged to be covered for the primary healthcare. If you look at how the healthcare has been focused, first we had the Alma Ata Declaration. It took 40-50 years for arriving at a consensus of a definition of health and well-being. Then to achieve that thing, the primary healthcare approach was envisioned, and though we have not achieved, but the primary healthcare approach was there, and it has been established now. Then after that, the Millennium Development Goals came. Then we have subsequently announced the scope of the Millennium Development Goals. Now we are having Sustainable Development Goals. The whole approach for achieving this is the primary healthcare. Now we are having a comprehensive primary healthcare for that. And to achieve that, another approach has been that with the comprehensive primary healthcare approach, you could be having a universal health coverage. So that's the financial catastrophe is there. While many efforts are being made for reducing, for having a diagnostic services, free diagnostic services, free this generic medicines things, but there was a need for having this kind of scheme. So this Ayushman Bharat, when it was launched, it is having two components. One is the Ayushman Bharat PMJ, and the other is the health and wellness component, which adopts the comprehensive primary healthcare approach, which is complementary to the primary. Because if you look at the scope, because 50 crore population is envisaged to be covered under PMJ, do we have adequate beds? If you look at the NSSO survey data, so the utilization rate is around 3% hospitalization. If 3% of Ayushman Bharat people, they utilize this scheme, then where do we have the beds? That's why the other scheme also become important, the health and wellness center, so that it acts as a gatekeeper. It doesn't allow the disease which can be prevented to land up in a secondary care or tertiary care hospital. Having said this, working in the previous program as well, when this program started, when we were just finalizing the package rates, there was a lot of representation from the providers saying that these packages are not viable. But having worked in the previous edition of this thing, because at that time it was just a precursor, it was mainly in an insurance mode. Whatever problems were there, we have tried to address this thing when we have launched this program. At that program, consciously, lot many things were decided during that time. We were knowing that the scheme uptake would be somewhat would be challenging. But as you have seen, 24,000 hospitals are there on board. And the beneficiaries awareness is also there, as mentioned by the speakers from Bhopal and Dr. Gupta. They mentioned that the awareness about this scheme is there. But for any such schemes to get popularized, it takes time. Now, in the coming days, you'll be seeing that more or less people will be coming forward and utilizing the scheme. The question which you have asked, whether it is reducing the out-of-pocket expenses, the measurement for whether the universal healthcare is happening or not, the NSSO survey round will tell us. But the other national health accounts and others, they have pointed out that the out-of-pocket expenses are showing a declining trend. It is reversing. That means it's less than 60% now. That means it's too early to comment whether it is impacting the out-of-pocket expenses, which is a way forward towards a universal health care. So the next round of NSSO survey will say on that. So one of the important, interesting things which has set in the community, this program, this Ayushman Bharat program and the precursor, it has empowered the beneficiaries. As rightly pointed out by Dr. Gupta, it has empowered the beneficiary. It has at least given a minimum rates in the community. Previously, now we know the benchmark. This Ayushman Bharat rates are there. They are the benchmark. Now, either you are giving your services below the benchmark or you are charging how much times you are charging above the benchmark. That benchmark is there. As the Manrega Health program has created a benchmark for labor services. This has provided a benchmark for health services in the country. There will be some resentment from the big hospitals and other things, but it's more or less targeted towards the people, the empowerment of the people, giving a choice to the people to walk into any of the hospital, the aluminum, the silver-plated hospital, and get themselves treated. That kind of empowerment is there with this program. And you can't imagine that kind of empowerment. Even I can't walk into a silver-chromed and this aluminum chrome-plated hospitals and get myself treated. But that kind of empowerment is given. This program has given. These two main things have happened. Benchmark in the society about the rates of the health services, and the second is the empowerment thing. When we were doing the enrollment during my earlier days, you see the need of this program. When I did the first card enrollment in Chhattisgarh, the people representative, Mahila Sarpanch there, way down in the Rajnandgaon, around 100 kilometers from Rajnandgaon in the Rajnandgaon district. We did the first enrollment. When I explained the people representing the Sarpanch, Mahila Sarpanch about this scheme, well, this is the thing we are doing. So there is a need, there's a health need for the people. It's not the health and the felt need, because it's very difficult to balance between the health and the felt need. There's a felt need for this kind of program. In any form, it is going to stay. And it, as you have mentioned that it's a game changer, it's already a game changer. It has disrupted many things. It has disrupted how to fix the package rates. Even the insurance companies also now they are having to provide a preferential network in which they fix packages, taking clue from such programs. So it has already disrupted the way things were happening. It's already a game changer in the coming days, because for any schemes during the early phase, it takes baby steps, and once it is maturing, then you will see more and more insights into that. And apart from that, NHA is also rolling out the National Digital Health Mission, where we can have a separate dialogue on that. But the National Digital Health Mission, I'm just closing it. The National Digital Mission also would be complementing the efforts made by the PMJ program.
Certainly. So we have a focus on that as well, and I'll again come back to you, Dr. Madan Gopal, to understand that how this digital health mission is also going to kind of strengthen it up, the mission, and how it is kind of as Dr. Divakar also said, that digital is the way forward. So how it is going to actually help us reach to the unreachable so far. Dr. Jitu Lal Meena, let me come to you. And so you have been, as I said, a very important part of bringing this pool of these hospital, which Dr. Madan Gopal says, the aluminum chromed and silver chromed hospitals. Though I think even the government hospitals are also now, some of them are being made in that style, but at the same time, it has definitely been, I think, an arduous journey for you, and convincing so many stakeholders, and keeping in mind that there has been a lot of those misgivings, and a lot of those doubts, and also concerns from these health care providers, especially the private ones. When you at this milestone, and especially on this day, which is tomorrow, which is 12th of December, is observed globally as a universal health coverage day, and we look at the Ayushman Bharat from the universal health coverage point of view, and that's a distant dream which has been. Dr. Meena, when you look back and see that, okay, you're all those hard work, and then this 24,000 pool of hospitals, I would like to hear from you, how do you see this scheme actually coming into the shape, and not only coming into the shape, actually being the game changer and changing the whole face of Indian healthcare, and and the work is in progress. And also I would like to hear from a little bit from you, that the challenges which you are still facing, because I still see a lot of hospitals are still out of the ambit of Ayushman Bharat. How do you see that? What can be the way forward to actually bring them also into the same fold? Dr. Meena.
Yes, sir. Good morning to everybody. First of all, I heartily congratulations to ISW Councils and Niti Aayog for this wonderful workshop. I really appreciate and give the opportunity as a speaker. As you know, when I appointment in 2000 as a medical officer in the PSC, I realized the number of the beneficiaries coming without shoes, and they are very poor, and they are very afraid the treatment. But when I see the implementation of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, I think it's really a game changer for the Indian healthcare scenarios. The important change of this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is one is the important, it's covers more than 50 crores of families also. And a very important thing is it's totally digital based, because most of the wrong problems is there in the manually, but when you come on the digitally, everything is transparent. That's why it's a very famous scheme, because each and everything is transparent. It may be a hospital empanelment, it may be identification of the beneficiaries, or maybe a claim processing. Each and everything is transparent and digital formats. So the time is also saved. Related to the hospital empanelment, you say it's not an easy task for me, that more than 20,000 is hospital is already empaneled with the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, or as you know, the 50% is from the private sectors. So it is also very important. And when we say for the treatment, more than 50% treatment is done by the private hospitals. Means treatment is more in the private hospital rather than the public hospitals. So it is also very important. And that's so that the private hospital is also very interested for this schemes. For the interesting part, because when I realized, previously I realized from the many others schemes from the government, because most of the hospitals say that in the government, we are unable to take payment on the times. And I think this is the key challenges in the Ayushman also. And so that we mainly focus on the payment. Because I think if any hospitals give the treatment to the patient and the beneficiary is safe, then why hospital is asked for payment to the government? Why not we give the payment advance rather than the hospital is asked for payment to me? And that's why we are mainly focused on the payment on time. And I think Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the only scheme where the 98% payment within 15 days. Within 15 days, 98% payment. I think this is the game changer. And that's why the private hospital is also interested to come to join the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Related to the claim processings, I also focus on the claim processing. Because previously, as you know, the doctors is best for the clinical sites, but it's less for the management side. But most of the time I am joined as a, not only for the clinician, also for the administration sides. And that's why I mainly focus on the administrations. So I focus on the pre-authorization process. I focus on the claim process. I focus on the role of the medicals. I focus on the role of the PMAM. I focus on the role of the PPD. I focus on the role of the CPD. And then I focus that how I standardize this process. And that's why I, each and every level, I standardize the process. It may be a pre-authorizations, that related to the document, standardization, and including the format also. Same thing for the claim processing. The how many documents need for the claim processing, which document in which format is need for the claim processing, and what is the query. Query is also specified. If PPD or CPD give the query, then how the medico is solve this query's problems with the evidence base. And then after the approval from the CPD, I also on the time at the ACO level or SSA levels or the bank level payments or not to the hospitals. And that's why after this continuously improvement process, I think this is the first time where the 98% payment is given within the 15 days. And as you know that Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the only scheme where the rejection rate is 1%. 1%. And it is because of the standardization of the format. Because we standardize and formatting at every level, from the PPD level, CPD level, from the medical level, from the ACO level, from the SHA levels. And that's why the rejection rate is come down 1%. Also the query rate is also come down from the 14%. Previously it is more than 40%. And because of the standardization, and continuously we take the feedback from the hospitals, from the insurance company, from the SHs, and that's why it's a continuously improvement process. When we say for the quality is the continuous improvement process. And after that, the hospital satisfaction rate is also increased because of the timely payment, because of the rejection rate is down, because of the carrier rate is down, and that's why the hospital interest is coming, and they are interested to join the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. We also focus on the hospital where some, as per the Niti Aayog, some aspirational district is also there where the lack of the hospital is there. Some focus district also there. So we identify the focus district, we identify the aspirational districts, and in the aspirational and focus districts, we relax the criteria of the empanelment because we are unable to get such criteria hospitals in the aspirational and focus district. And that's why we relax the criteria, because our main goal is the beneficiary's health rather than only the empanelment for the criterias, because 1 hour is the golden periods. So we want that the nearest of the nearest hospital is provided by the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And that's why we relax the criteria in the aspirational and focus districts. We also give the automated empanelment, like if hospital is NABH accredited, CGHS impaneled hospital, ECHS impaneled hospital, so they are automatically impaneled. So the time of the impaneled is also reduced. We are also give, if any times the DEC district empanelment committee take more than 7 days, then automatically impaneled. If SCC take the more days, then automatically impaneled. So we are the time bound manner for the empanelment also. And that's why the hospital is satisfaction, because they are also happy the empanelment within the timelines. We are also give the incentive. If your hospital is quality oriented, like the NABH accredited, we give the 15% incentive. If you are NABH entry level, we give the 10% incentive. If your hospital is teaching hospital, we extra give the 10% hospitals. If your hospital in metro cities, because we know in the metro city, the infrastructure cost is more. That's why we give the 10% incentives. And we are also giving the aspirational districts hospital, because we know in the aspirational districts, the manpower cost is high. And that's why we give the 10% incentive. If your hospital is bronze quality certified, then we give the 5% on incentive. And that's why the quality hospital is also coming in these pictures. Another important thing in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, it's a continuously improvement process in each and every level related to the package. Previously, it's the HVP1. Then we take the feedback from the SHA, hospitals, insurance company, and we change from the HVP2. After taking the feedback from the HVP2, we release the HVP 2.1. After taking feedback from the HVP2, we release the HVP 2.2. And you know that within 3 years, we change this package rate 3 times after taking the feedback from the different states, from the insurance companies, from the hospitals. And now we are continuously improvement process that every years we take the feedbacks from the hospitals, state, SHA, insurance company, and we change the package rates in every years also. In related to the empanelment, we also take the continuously feedback from the empanelment process. Then previously is the HEM1, now the changes of the HEM2. The process is also down. Previously the more than 800 thing is there, but now only the 300 or 500 thing is there. So we continuously improvement the process also. Or related to the TMS part, TMS is also previously it's because of the lack of beneficiaries, but now the beneficiaries load is increased. So the speed of the TMS is also increased, and from TMS 1 to TMS 2. So that's why it's a continuously improvement process related to the universal health coverage. As you say, the universal health coverage, because we previously identified the 22 insurance companies. Out of 22, we already 11 insurance companies already agree and signed the MOU for the missing middle project. Because as you know, the 50 lakhs is already covered in the Ayushman Bharat beneficiaries. The 10 to 15 lakhs is already covered, extra covered from the state also. Some, if you know that about 10 to 12 crore is also covered in the government, private insurance companies, and about the 15 crore in the CGHS, ECHS and other. So remaining only 20 to 25% is remaining. So we give that chance to 11 insurance company which has signed the MOU with the NHA for the piloting this missing middle project and identify the how the cost is generated. If the costing is coming, and then we are also thinking for the universal health coverage in India. So we are continuously improvements. For the automizations, we are also give, if your hospital is purely clean, neat and clean, then we give the advance payment in the green channels. First, you submit the claim, immediately your 50% amount is coming. That means it is just like a case payment. Because you 50% get payment within the submission of the claim. If your hospital is neat and clean within 6 months. And I always believe if you want to improvement, then you appreciate the better quality healthcare services rather than the punishment of the poor quality healthcare services. If you appreciate the better hospitals, then scheme is 100% progressive. Because the remaining hospital thinking, why we not getting this green channels? They are thinking for the process that it processes something is wrong in the process. Related to the fraudulent activity, I think so. In the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the word class of fraud activities detection is there. Related to the call center, we have the 24 hours call centers, and within timelines, the answer is given to the beneficiaries, to the hospital, and other things. So I think it's really a game changer for the health care provider of the India. And I 100% appreciate that Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the heart-touching scheme of our honorable prime ministers. And after this COVID situation, I think this is needed that universal health coverage is very must for the India.
Yes, sir.
Yeah,
Absolutely.
we are 100% progressive on this for universal health coverages through the missing middles and other things. And
Absolutely.
and some district does not have some hospitals. So we incorporate the bank, like the SBI is also coming in front. That SBI give the loan to the districts where the hospital is not there.
So that we can get new hospitals.
So we will create the new hospitals. So we thinking each and every levels related to the hospital, related to the beneficiaries, related to the treatment part, related to the claim processing, because in the process we are also have the standard treatment guidelines, so that the unnecessary procedure is not done. Related to the diagnostic procedures, we are also differentiated the diagnostic. Previously, it's only the bundle process, but now we change that diagnostic package is also separated. And we give the diagnostic package through the e-voucher, so that if any procedures identify the diagnostic procedure according to the standard treatment guideline, the e-voucher is given to the beneficiaries and they go to the lab and they test it and the e-voucher is rolled. So this is also very important to decrease the pocket expenditures.
Thank you so much, Dr. Meena. You have the way you have described the all those aspects and very meticulously taken care of each and everything. This is just sound like a dream, scheme being implemented bit by bit and with the improvement, in mind at every step. And also, it's very heartening to know, and that's what I think Dr. Gupta was also highlighting, Dr. Madan Gopal has also highlighted, that this Ayushman Bharat scheme has also triggered the whole systemic transformation also. So we can't only have the existing healthcare system being utilized for the people, but we need to create the whole new system and infrastructure also. Some of those things are really amazing, to hear just that advance payment, getting advance payment for a government scheme is something I think has been unheard of. Every time I talk to my, the people in the healthcare system, they say, CGHS payment come 6 months after, the treatment, 1 year after the treatment, we are cash crunch, we can't keep, providing the, so those are the problems which are, this government and private relationship has been facing, and which is being transformed absolutely as per your description under this scheme. We have with us Dr. Hema Divakar also, and she runs a hospital in a kind of a metropolitan city of Bengaluru. Dr. Divakar, are you Ayushman impaneled hospital?
Thank you, Kamal. We have applied for that, and I'm so grateful to the two distinguished panelists who have given so much insights into what doesn't meet the eye very easily, because there are so many steps in the micro implementation of this whole scheme to reach the meaningful endpoint. And it was a mind-blowing insight into what it takes and what it involves. Yes, we have applied for the Ayushman about in the COVID times when the Suvarna Arogya Trust SAST portal was opened up, and there are still some documents that they have asked us to upload, and the process is on. Dr. Divakar is really after their life, because it's my dream also to see how this public-private partnership and the low-cost but quality care can be empowered. Even in the state of Karnataka, in the district of Chamarajanagar, about 18 years back, we had partnered in public-private partnership in a small village where an FRU, first referral unit, we took on as private providers, and we said we will train the staff and we will do as per whatever scheme the government is giving. So it was only 3,000 rupees per delivery. So if you do 10 deliveries per month, you get 3,000 into 10. But if you do 100, you'll get 3,000 into 100. So that was the scheme. Within 3 months, the quality of care escalated, and there were more than 350 deliveries per month in a center which was doing only 10 deliveries for the whole year. That was the kind of escalation. And the costing also, it worked out very well for us, and the extra monies that we got, we put back into the system to upgrade the equipment, to get in more staff, and to do. So it is, doable. That did not progress ahead because the reach was very limited. We had to go on site physically and train people, and it was very human resource intensive. And that's why I'm always excited about this digital mode. The three things, the buzzwords which we always use: access, affordability, and the awareness. So I must say, on these three words to play, awareness, I feel that the healthcare awareness, many people through the digital platform, directly the consumers know. Awareness about these schemes, awareness about how to get there. Organizations like Hak Darshak, what are their rights, that they show the mirror to them. Those things are really crucial, and we are trying in our own way to enhance it so that people who really need it should avail of it without any barriers in their mind. And accessibility, yes, with the digital platform, back end, so many things are accessible. So that on the face of it looks very easy, but the accessibility should be coupled with capacity building, because the early detection and early care and prevention, the same finances of Ayushman Bharat, we can treat double the number of patients for half the cost, because they are not lining up there at the fag end of their disease process, but they are either preventing it, the communicable, non-communicable, everything comes in that category. Affordability, unquestionable when the scheme expands and reaches every nook and corner. The reassurance to every citizen that yes, it is an affordable care that we are finally getting at, already can change their mindset into a positive and a healthy kind of a frame of mind, which empowers them to have the courage to say that my health is in my hands. And oftentimes I say it's not only the private practitioners, it's not only the government, but the citizens also have to be responsible for their own health. They have to also walk 2 steps ahead. And lastly, I would like to close with what Dr. Meena said in the previous forum of Samvad, that the e-vouchers, I think it's a brilliant system, because he said there are e-vouchers just for a hemoglobin test. Okay, so you go, and it so well aligns with our Shapath initiative, Kamalji, that everybody gets an e-voucher, entire district, lakhs of women, at least we know that testing is done. Treat and talk, that is the T3 mission of the government. We go 1 step at a time, but we are constantly moving forward. So that is the message I would like to give. We've started the long journey with 1 step, several steps to go, but the direction is correct, the conviction is correct, and we have the courage to move together. Thank you.
Thank you so much, Dr. Diwakar. And actually, it kind of validated the point which Dr. Meena made, that hospitals are now getting encouraged, and the satisfaction level has increased. And that's where, when you say that you have applied to be part of the Ayushman Bharat, it shows that the hospitals are now, and there are those who have been kind of been part of it for long, but there are more and more people, healthcare providers, and those really care for the people of our country are joining this the great mission. Let me go to Dr. Madan Gopal, and the last remark, and after that then we will move ahead for the next session. Dr. Madan Gopal, Dr. Hema Diwakar mentioned an important aspect, and you also touched upon that the preventive side of Ayushman Bharat also need to be equally taken care of. While we are seeing, and as Dr. Meena described in so many details, that how this PMJ, which is primarily for the secondary and tertiary care, is kind of focusing and ensuring that the care reaches to those who are in need of it. But at the same time, and as Dr. Diwakar also said, that we can save and kind of make many more people healthy in the same finance which Ayushman Bharat has, if we are looking at the early detection, early and prevention of the diseases, and stop the progression of that. I want to understand from you that how much progress, and from the think tank point of view of Niti Aayog, where you are looking at on a broad movement of all policy areas, how much we have actually moved on that. So when we have these big numbers, 26,000 crore worth treatment have been provided under Ayushman Bharat PMJ. From the preventive side, where do we stand now, and how we are moving ahead?
A very interesting question, because if you have heard what I was speaking, for the last many years, our focus has been on the preventive promotive care, the primary health care. And we have done tremendously better on the primary health care. If you look at the indicators which are there, our approach was primary health care approach, which was then later on made as a comprehensive primary health care approach. We are having package of 12 services to be offered at a ground root level. If you look at the structure which has evolved over the many years, at the city level, you are having at the district level, you are having a medical college in the district hospital. Then, if you look at the revenue structure, it corresponds to the revenue structure. We are having a health institution there. That means at a block level, you are having a block headquarter in the form of community health center. At the sector level, you are having a sector headquarter in the form of primary health care, which caters to 20 to 30,000 population. At a section level, we are having a section headquarter which is called a sub-health center, which caters to around 5,000 to 3,000 to 5,000 population. Now it will be catering to more population. Okay, all these sub-centers, they are already there. We are having around 1,70,000 sub-centers. And we are upgrading these sub-centers and labeling them as health and wellness center. It's not that health and wellness centers are not there. They exist. They are providing 6 packages of services. We are expanding the scope of these services to 12 packages. As and when more packages are added, a community health officer is there, we say that it is functional. Out of the target of 1.5 lakh health and wellness centers, which are to be made functional by end of December 2022, we are more or less covered the midway mark. That means around 80,000 health and wellness centers, they are now functional. Apart from that, the remaining 70,000, they are providing the other set of services. They are already doing it. To complement the effort of these services, we are having a battery of healthcare workers. At each and every village, you are having a community health volunteer who are labeled as ASHA workers. We are having more than a fleet of around 10 lakh ASHA workers. So these are a lot of efforts which are going on, and this is making a lot of progress has been achieved. Now you have to see that how it complements, because people are coming. The referral mechanism between this section to the PMJ, that needs to be looked at, and already work is going on in this direction. How to complement the efforts made here can be complemented with the efforts made there. That program is there for the last many years before this. And if you look at the financing, you have mentioned about the same kind of financing. No, the major finances go to the primary and the primary health care. Because you look at this, if you look at the budget which goes for the primary health care, is around 5 to 6 times than the Ayushman Bharat budget or this PMJ budget.
Dr. Madan Gopal, just one more add-on question on that. How this National Digital Health Mission is going to actually, kind of help us additionally reach out to more people in terms of the preventive and primary care? Because there is one component of telemedicine also involved in that. So how do you see that? Is it going to kind of...
Time is too short to explain all this, but I will say that digital mission is targeting digitalizing the patient records. That means each and every person would be having electronic health record. The hospital will be having a digital ID, and the provider would be having a digital ID. Right now, they are focusing only on this aspect. But if you go back to the other aspect, the health which is there, the whole effort for digitalizing started from the Clinical Establishment Act way back in 2011, where it has been mandated that all the hospitals which are registered in the Clinical Establishment Act, they would be having an electronic health record. It is a step in that direction. With PMJ in place, they are enforcing the electronic health records in the PMJ hospitals. Now, this would aid in achieving that mission, because the mission is rolled out in phases. In the coming years, we will be seeing more about the electronic health record being used for management of the patient as well as for the surveillance. In the Niti Aayog, this disease surveillance document, Vision 2035, we have told that the surveillance in the future has to happen through the electronic health record. And digital mission is a movement in that direction. I will stop here.
Thank you so much, Dr. Madan Gopal. And I'm sure. So on this, on the eve of World Universal Health Coverage Day, we again, reiterate that the mega scheme, the ambitious project of Ayushman Bharat, which was initiated by the government of India under the leadership of the Prime Minister. We heard that how it has helped reaching and taking the healthcare to many unserved and underprivileged people. The numbers are, telling, and they actually underline that how this vision is materializing, and we as a country are inching towards the larger dream of achieving universal health coverage for all, for everyone, which can ensure equitable, accessible and affordable care for all those who need it. The next session will be discussing the Ayushman Bharat's the other components, the mechanism of its delivery of healthcare, how we are going to improvise it, and we have some wonderful speakers joining us for that as well. And those who have been leading or taking this torch of Ayushman Bharat forward, and it will be moderated by our advisory board member and also the CEO of Artists for Her, Dr. Hema Divakar. So with this, thank you so much, Dr. Madan Gopal, Dr. Jitul Almina, for your wonderful insights which you shared. And over to you, Dr. Hema Divakar, for the next session.
Thank you, Kamal. On my own behalf, I thank the distinguished panelists in the previous session as well, which was a very delightful deliberation, because bringing ourselves together, breaking the silos and getting our thought process ahead is a major step indeed. So vision, mission and action, that is the three main ingredients of the recipe for those who are very actively involved in taking the NDHM, National Digital Health Mission, to deliver the healthcare. And I'm very delighted to have my next distinguished panel in the form of Dr. Ratan Kelkar, IAS Mission Director, National Health Mission, Government of Kerala, Dr. Bhaskar Katamnini, who is IAS Commissioner, Health and Family Welfare Mission Director at the Government of Andhra Pradesh, and Mr. Nishant Jain, who is the Program Director of the German international corporation called the GIZ, and our very own and beloved Dr. Suchin Bajajji, whom I have interacted many times on this forum and outside of this forum as well, who is the founder director of the Cygnus Hospital and expert market access to the program PMJ. So let me start by thanking all our distinguished panel for their time invested in participating in this conclave and deliberation. My first question is to Dr. Ratan Kelkar. I was so excited to read about Ratanji, who is from the Bengaluru Medical College, where I belong. And then his statement of saying that the IT sector should be, as if in the private segment, it should come into the fold of the government, and we should be using it and exploiting it to the maximum to reach everywhere for many things that we can do in the digital. And he very proudly, I can say that very strong implementation in the state of Karnataka and now in Kerala as well. And recent COVID situation, there was a comment, sir, that you said, despite everything going digital, there have still been challenges. So the opportunities and challenges, which are like two sides of the coin, can you reflect and tell us what we have done so far in inculcating the behavior change of go digital in the health system? Because if you can recall, even the citizens, may it be any age, they will book their flight tickets through the digital, they will do the shopping on the digital, they'll even buy the groceries. But when it comes to health, there is a little, we are moving ahead, but we are moving a little slowly. So what was your experience previously, as how now we have positioned for more work, the deliverables in the healthcare system, and strengthening what are the benefits that we are reaping with implementation that you have led?
Thank you, Dr. Hema. It was nice to listen to you talk about what I have spoken some time back
So that means you've done a lot of research on all the speakers as well. So coming to the point, I've always believed that technology, a tool which will make people convenient and easy. If we have a mind to look at it that way and have a golden handshake with the progressive IT implementation, it need not be in one particular sector. It can be a digital transformation, which, like you rightly pointed out, is happening across the globe. And there is absolutely no reason why we can't embrace technology for delivering the most important services of all departments, including health. And one of the most important activities of the national e-governance have always been giving the services at the doorsteps of the people and at the fingertips of people. That has always been the motto. And that is the way in which we need to look at it. And to look at it in that way, you need to have a change of mindset. I think that is the most important aspect which I would feel could be a hindrance in embracing technology. If technology is believed to ease out the life of people in achieving some desired results, which you would otherwise do manually, I think there will definitely be a proactive approach from everybody. But if it is seen as a tool which is going to replace human interface and take up jobs which are meant for others, then that will definitely have a bit of an obstacle. But I would like you to just reflect back on a time when computers were being introduced for the first time in in the country, especially in the government sector, and there were huge issues of implementation because people all believed that the computers will take over the roles and responsibilities of human, and people will be losing jobs in big numbers. But that mindset has changed over a period of time, and now we see that all the technological advancements are now being embraced by one and all, especially in the government after the National E-Governance Plan, which was started, and subsequently all the services are now being made IT enabled. People would not have to move from office to office asking for a service, and now at the fingertips through the mobile, all the services are getting delivered. Now, coming to the health sector in particular, there is actually a challenge in implementation of various IT initiatives, because over a period of time, we've seen many legacy systems developing in all departments, including health. So health has its own legacy data sets, which are now getting integrated into the most recent advancements in technology. You can take, for example, the IHIP, which has come into being after an upgradation from the IDSP. Parallelly, all the states have their own legacy data sets. And when you look at implementing NHDM, we cannot say that I will bring up something and it will replace everything. And during our last meeting with the NHA also, there was a lot of deliberation on what should the NHDM be doing in terms of being a middleware where you can ask the states to plug and play and utilize all the benefits of this middleware, as well as the desired results of the national registry in terms of professionals, in terms of creating that universal ID, which will be a health ID, which will be one single source of truth, which will probably be riding on the database of Aadhaar, and also all the health institutions, including diagnostics, including pharmacies, all the various components and verticals of health system will also embrace NHDM, provided there is a movement to create that kind of a workspace for all of those legacy systems as well, because people are used to the legacy systems. We cannot replace all of them, but yes, you can integrate efficiently all those legacy systems into what you're looking at doing with NHDM. So if the NHDM is looking at creating a registry, if NHDM is creating the health professional data sets, if all the EHR is supposed to be available nationally so that there'll be very good patient mobility across states, I mean, nothing like it. I'm sure it is going to happen, but yes, it takes some time in terms of planning, understanding what are all the legacy systems existing in the private as well as in the government, what are all the integrations you want to have to these data sets through an API integration. And parallelly, we also need to ensure that this middleware has all the freedom given to the states and the private sector not to disband their legacy systems if they're very comfortable with. They can always use this if they are happy, a full suite of this NHDM if they're happy to use because their legacy systems are not up to the mark, probably at a particular fee. Otherwise, they should be allowed to use their legacy systems, because only then slowly and in small steps can you achieve these kind of results. Otherwise, a big bang probably when there are existing legacy systems will be very difficult to implement. So, if I'm talking about Kerala in particular, we already have a lot of actions already in place. We have more than 500 hospitals, that is health facilities, already using e-health, which is a EHR at that level. We have various modules already running. And through discussions with NHDM, we understand that there will be an open API kind of a setup where the states can transfer whatever is the required data to the national registry, parallelly use all the national registry database elements for the state's benefit, so that we don't disband what is already functional and take over, which gets a bit more complicated. So there'll be space for everybody in this ecosystem so that we can all utilize the IT advancements to the maximum extent possible. And a lot of work is happening across the country, and NHDM, now we call that ABDM, under the leadership of the CEO NHA as well as additional CEO NHA, have been doing extremely good work. They have been interacting with all the states. We are also very closely working with ABDM. We've already started testing some of their APIs in our sandbox, and we are looking at methodologies of integration with ABDM. And it is very nice to hear last time when we had this conference conducted by NHA and of course the co-host by GIZ, that there will be enough opportunities for plug and play as well as maintaining legacy data assets for every state and moving together in a very coordinated manner. I think we'll be able to achieve wherever it is needed to be fast tracked, we need to do that, and wherever it is needed to be handheld and hand-holding is needed for the states, that needs to be done. Otherwise, it's a wonderfully thought of project. I think we should all be supporting each other in ensuring that this comes up at the earliest. I'll stop here.
Yeah, thank you, Dr. Athar, because you've been one of the fastest first movers, if I may call. And then, there's a large canvas that you have, laid before us as to what has already been achieved. One small follow-up question. When you reflect back, sometimes too much data on the digital system with one individual has to enter, it gets overwhelming because it's a little bit of a behavior change. And at other times, you reflect that if you don't capture everything, you have tackled one vertical and then you wish, oh, not again. We could have captured something else like pregnancy and NCD, for example. You could have as well plugged it in there and made it happen all at once. So what are your thoughts about the practical problems with this kind of a thought process?
Okay, now when this Aadhaar came into being, there was also a concept of a state resident data hub. That means all the related information would be residing on that data hub. Like you rightly pointed out, if one department is asking for one particular data set, the same thing need not be asked by the other department. Only the additional data sets need to be asked, which is more relevant. So now what we all need to understand is, if you're trying to IT enable everything that you're doing manually without any business process re-engineering, then it is going to be a huge failure. For example, we'll give an example of the Asha diary. Asha diary captures almost everything that is needed in the, for the understanding the health of the particular household. And if an Anganwadi, the CAS system which is in existence, wants to capture the same thing over and over again, that makes no sense at all. And coming again to another department, a tribal mission department, which wants to give some facility, they want to understand something about this household. We are again, collecting the same data set. So the proper way of doing it would be having a integrated data set, which would probably something like NHDM, which will not keep asking the data over and over again, and only the relevant data is needed. Right now, we ask each and everything, which probably nobody analyzes or no action happens on that data set, but as a part of some legacy manual procedure, we have converted all that manual procedure into an IT system where people sit and do the data entry, like you have pointed out now. A very how this business process reengineering has happened in the recent past is the CoWIN portal, which we have started entering the COVID vaccination. There, when a person is registering, you just put in one particular document, your name and a telephone number. You don't go behind asking their PIN code, where they. I mean, that is not needed at all. Do we want to know why we want to have each and every detail of a particular individual, especially in a setup where all this data is captured at the time when the person is born? When a person is born, you capture each and every data of that particular individual. And if that is residing in a resident data hub, there is something called a life cycle approach, wherein once the data is captured at the time of birth, for example, you don't have to give any data till you die. I mean, there is a setup, a concept which is already in existence, which is called a life cycle approach. Once you give a data, when you're coming very close to 5 years, you would have covered all your immunization, because all that information goes to a concerned person that this person is due for immunization and he or she has to be given. When you're entering school, all of this data goes to the school. You don't have to capture anything else apart from their academic profile. And this academic profile automatically goes to the higher education. This automatically goes to the place you are going to work. And subsequently, if you're getting married and all that, that data set gets created. So ideally, a person, once he or she is born, they should not be bothered about collecting these certificates, running behind various systems. We should follow this life cycle approach, wherein all the data relevant to an individual resides in a data hub. And the system should be so agile that it will throw all the required things at the fingertips of a person as and when that person becomes eligible for a particular requirement. If you're going for a building permit, all this data goes to that the Department of Urban Development, where they don't have to do anything else, because the entire history is there. Whatever is the relevant thing that department needs to work on. I mean, that kind of thinking should come, where all the data sets get merged into one massive data set for a particular individual, and this person should not be asked to produce anything at all, because all this data is already residing with us. And I think that is the way in which we should move forward. I think we are moving in the right direction, but being a legacy issue, a lot of things need to be put in place before we even think of what I've just mentioned.
Thank you so very much. This is music to the ears of Kamal, Narayan and myself and rest of us at the ISW Council, because our vision is to break the silos, get everybody onto a common platform, discuss the way forward, and you've laid a beautiful roadmap, and it'll be a dream come true if it goes in that channel. Let me just shift focus to Bhaskar Katamneni. I'm not sure whether I have pronounced the name properly, sir. You said that it is also your dream to reach the last mile and the last person, but you don't upfront agree on the fact. Of course, now the physical conferences are happening. Even we as doctors, we say enough is enough for the digital. Let's do a hybrid. Let some people come to this. So there has always to be a blend of two things as a in-person consultation, human touch, etc. But it comes across that you are a strong believer in the fact that without that human touch, everything cannot be achieved on the digital platform, which is so very true. But given the country context, and given that we have to reach at least the primary healthcare to everybody because they deserve at least that much, the Mercedes-Benz tagline, which says the best or nothing. If we want to go in for the best, that everybody human touch, then we'll have nothing. That's how it is in our country. So we have to have a blend. So what is your present thought process as to how we can integrate the care at the digital level and at where they actually need to come to the clinics to have a value for their visit at the clinic, as in the point of care devices, where does that fit in? Because semi-scale, home to home, they can do a lot of things. And then they can convey to the central hub. And then only those who are not in the green channel can go over there and then get moving forward. So what are your thoughts and what has been your experience, sir, in the NDHN? Bhaskarji.
Thank you, Dr. Hema. And that was a perspective which is floating around, that, We are digitizing everything. A lot of sectors, a lot of digital data is being created, and in health sector also. And somehow I think there is a perspective which looks digitizing as a solution for everything. So I have an alternative perspective. Digitization is required. Digital interfaces are required. But let us look at India. India, we are a very diverse country. So the bandwidth availability at different places is of different levels. Within my state also, there are pockets where there's absolutely no bandwidth available whatsoever. And these are the places where, the requirement for medical attention is also the highest. It works that way. The tribal areas that I have are areas where the network is not available. So availability of medical personnel also is an issue there. It's a double bind. You don't have this and you don't have that also. So that is the perspective in which we need to work, and that would be true for many states. Kerala is always an exception. Kerala, we always look towards Kerala as like the leader in terms of healthcare, because their infrastructure, the level of availability of medical professionals and all is of a totally a different level. What I wanted to say was that our experience in the last 1.5 years has been that digitization helps. Digital interfaces definitely helps. They can be only a layer over what you have as a base. If you don't have trained medical professionals, you don't have trained nurses, paramedics, and you don't have trained pharmacists and all. So without that base being there, whatever layers of digitization you want to add, you're not going to go far. So for example, I'll tell you the teleconsultation platform that we have. So we've been using it for last 1.5 years, fairly at a higher level. So even today, I think half of the teleconsultations in the country are done in my one state. But we are not able to scale up beyond one level, because we are hitting a wall where what happens is that, so those people who are comfortable talking to a doctor or a video consultation or a teleconsultation and then getting treated, there is a particular subset of people who are okay with that. But beyond that, you require a physical touch point, that thing. And second thing is that I'll give an example. You talk to a doctor over phone or on video consultation, fair enough. So what the doctor is doing is that he's asking you about the symptoms purely based on what you are telling the doctor. He's coming to a conclusion. All of us can agree that the diagnosis of the doctor is definitely not perfect. You have not seen the patient this thing. What we need to do is that add more layers of information coming in. That is only possible through a hybrid model where the doctor requires for particular diagnostic tests. Those tests actually have to be done physically, and then data again has to be shared with the doctor, so the diagnosis is better. That's what we have been experimenting with in version 2, where our functionaries like MLHPs and our AMMs are basically doing the test using our rapid kits and then sharing the data with the doctor, where the diagnosis becomes really better. And then the patients are basically accepting the IT platforms for accessing healthcare services is definitely better. And since this is health, we don't want any wrong diagnosis happening, and on just phone something is happening. So basic, very basic things for teleconsultation works fine, but for anything more than that, I think you need to add definitely more layers of both physical interface as well as digital layers also of both collecting data and this. And then as the other speakers have indicated, the large number of silos. So the last time we counted, at least in health sector in our state, there are 54 different sets of databases and they don't speak to each other. And I'm only talking about health. And our other departments like civil supply department also, a large number of data is there with them, which is very relevant for the health. And women and child welfare, we find that at least 50% of data sets, they also collect separately, and these data sets they don't speak to each other. The digital health mission is a step in the right direction that, like we have done in Aadhaar. seeding of the digital health ID to different health sets, data sets will make it easy for integrating the data. And then you'll have a proper MIS system both for an individual or even for a village, even for a block or a district, to have an understanding about, what kind of communicable disease or non-communicable diseases and what kind of prevalence is there, and what kind of social and demographic parameters are affecting this kind of a behavior. And that would basically make us, understand things better and plan better and ensure that, we take it. So what we would say is that based on this experience, what we are doing is that we're doing both parallelly. We are recruiting doctors parallelly, we are recruiting paramedics parallelly, training them, retraining them. That part we are taking. The other part is that building our network, basically the backbone, broadband, connectivity at all places, that is happening parallelly. And the third thing, that is the digital health mission, creating digital health IDs for citizens, seeding it to the databases, that is happening. We are working closely with the digital health mission, and we have taken a slightly different approach that, we go to the people house to house like we have done for Aadhaar and create the digital health ID then and there itself, rather than waiting for, for people to come to our hospital. And then when they come to a point of care, then we create a digital health ID for them. Maybe that is also a correct, good approach, but that would definitely take a large amount of time, because expecting that all the citizens will end up in some health facility at some point of time, and then we'll create a digital health ID for them, and then the database will be seeded. It is one approach, nothing wrong in that approach, but we have taken a different approach that we are basically going house to house and then basically creating a digital health ID and then seeding the data so that, simultaneously digital health ID is being created. The moment one individual digital health ID is created, that is used to seed his health ID into all the different data sets which we currently have in the state. Of course, the different data sets that Government of India also operates, I think over a period of time, they will also be doing the same thing. So, of course, that has to be done by the states. The clearances will come from there, and then we'll be doing it. I think it's quite a long road ahead of us. I think we are looking at an horizon of 3 to 4 years, at least in case of our state, where the parts of all the puzzle will come together, and we will see. We are already seeing benefits of some of these things in that few data sets we have already started, merging using the digital health ID, and few villages we have completed, and then the results that we see are really, we never thought that these kind of correlations are there between certain behaviors and certain disease profile and all. It's giving a very good perspective to take care of population based medicine, and I think quite exciting times for us, and then we look forward to move on the road ahead. Thank you.
Thank you so much, sir. Points very well taken, Mr. Bhaskar Katamneni, because there have to be the meeting of the unlike minds and different viewpoints to place the pieces of the puzzle together. And one shoes doesn't fit all. So each of the states trying to work out, but through a common forum or foundation of reaching everybody digitally for a variety of purposes, and our lessons learned, and we move forward. There's one small follow-up question, sir, I want to ask you. You brought out a very important point that, yes, not everything can be done digitally. And then there is a wall where we have stopped, even though, we progressively went ahead, but because there's only this much you can do. And then the next step is that, some interaction at the in-person meeting also has to happen. Well, we agree on that. There are some softer aspects in health, like, the youth of the country today who are so highly hooked on to the digital media. The mental health is becoming a huge issue. So the confidentiality and anonymity with which they love to seek help on the digital platform is, it's reached enormous proportions. So also some women and girls, for their life skills and sexual health problems and menstrual issues. So all of these are also, integrated, because the awareness also can be through the digital platform. The capacity building also, because the quality is much to be desired when these people actually come. What is there in it for them, unless the quality care is delivered? What are your thoughts on these newer aspects where we could, move faster than what we're already doing, focusing on those low-hanging fruits where digital media can be fully exploited?
Yeah, definitely, because the youth today are basically more accustomed to social media and also are using the digital platform. That is the one positive part of it. And the negative fallout of the same also, basically digital addiction and all, will also become an issue. Currently, there are issues and they'll become, larger issues as we go by. So what is happening currently is that, I should agree that, we are not using it to the extent that we should be using. Currently, the programs that are run for adolescents and all, or a large number of programs run by basically spearheaded by Government of India, are not happening in the digital platform, with the exception that we have a toll-free number where the youth are encouraged to call, and then the follow-up to the call is done physically again at the PSC level and at also the CSC level. That's the current system that we have. The entry point, there are two entry points that you can walk into a clinic. We run a adolescent clinic every Friday for girls and every Saturday for boys in all the primary health centers, where basically a trained psychologist and a social worker along with the PSC medical officer gives the basic services. And if they feel that the services which they are offering are not sufficient because it requires a higher level of involvement, then the cases are referred to the next level. That's what we are doing. And parallelly, they have a toll-free number where they can call in, and the follow-up to the toll-free number call is again given to the field functionaries at CSC and above level, where they basically follow up the cases. That is happening, and I agree. And the digital platform can definitely be used for this subset, because this subset is very much accustomed to using technology, and it's both a problem as well as a solution also, both in one. I definitely agree that that's the way to go, but it's a long way. So definitely, I think when I said not everything can be done digitally, it's with a condition that not everything can be done digitally today. So definitely, as technology evolves, as artificial intelligence comes into picture and all, our diagnosis using digital technologies will become better in future. What we say today will not be true for a decade later. Definitely a decade later, if we were speaking, so definitely the acceptance will be better, and the outcomes will definitely be better even in the medical field using technology. But what I'm talking about is current today's this thing. I'll give an example. Rather than going to an unqualified RMP, which we call a person, the quacks, definitely teleconsultation is 100 times far better. So if a facility is available, a citizen would prefer basically to call a proper doctor and get diagnosis rather than going to an unqualified person, where they go, because today there is a availability issue. That gap definitely we can do currently using the teleconsultation, and not at specialized services, which I think we are still away in terms of the technology which is currently there. I think it has to go up by a few notches that it becomes really in a mainstream technology. Thank you.
Thank you so much. Both of you have given such honest, mature, and positive kind of a feel for this entire mission of the National Digital Health Mission moving ahead, bringing forth the challenges, the limitations, where we were to where we are and where we could go. So really, really appreciate your inputs on this very important issue. Both of you have talked so much about data, and some silos not talking to another. The data person is right here with us, Dr. Nishant Jain. Germans are very precision driven, and he represents the GIS, the German organization, which has gone far ahead in collecting the data and evaluating it and presenting it in the different geographies so that the lessons can be learned, the trends can be studied, and the way forward direction to consolidate our implementation strategies. So what has been your experiences, Dr. Nishant Jain?
Thank you. Thank you, Dr. Hema. And thanks to Ratan and Bhaskar for very interesting insights which have come. And, I really like what Bhaskar said, that what can be done today, that is what we can talk about, because things change very quickly. Nobody had thought 18 months before or 19 months before that we're having so many meetings on Zoom and on these technology platform, because without physical meetings, nobody thought of having any of these kind of meetings. But we were forced to do that. We were forced to innovate, and technology played a very critical role there. So I am very sure that the way technology is evolving and the way infrastructure is also evolving, things will keep changing. Similar about telemedicine, for example. In India, telemedicine is there since so long. People keep trying to experiment at different pockets. But during the last 1.5 years, during pandemic, telemedicine really picked up. A lot of cases started happening where even the providers were forced to offer these services. They created the technology platform to do it, and even now, Government of India has guidelines for that. That how it can be done, because there are chances of misuse in this also. As Bhaskar was talking about quack and all, these RMPs. So similarly in telemedicine also, if you don't have adequate regulations, if you don't know that who is sitting on the other side of the patient, on the call, whether that's a qualified person or not, that also we need to ensure. And these guidelines have really helped, I think, which the government has come out with. And these are part of the ABDM, like NDHM was the old name, as Ratan mentioned, now it's called Ayushman Bharat Digital Mission. So these are the part of the ABDM framework. So in that sense, I feel that India has a lot of opportunity to learn from others and go much beyond. Because, this quotation is always there, that I could see farther because I was standing on the shoulder of giants. So the idea is that we need not reinvent everything. We can actually learn from a lot from others, what mistakes they have done and what good things they have done. And I think this ABDM provides a unique opportunity, because we all had so much fragmentation, and Bhaskar very rightly gave an example that so many different data sets are there in one state, in one department of health. And the situation is not better in any other state, he will certainly know. In some states, it's even worse. And then the other angle of that is that in many cases, the data is not even digitalized. This data is in paper, in registers, in forms, and there's no idea. But now the thought of having a unique digital health ID, which will be given to every person, and then whenever the person visits to a healthcare provider, that health ID gets linked with your health records. That is something is a very powerful tool. But at the same time, I think we need to be very sure about the privacy, about the security of the data, about the data protection. All these things become very critical, because in our country, the laws are not so strong on these things. And that's, or if they are, then at least they can still be misused. So in the European countries and all, there are very strong laws about these data protection and all. Sometimes we say they're too strong for their own good, because you can't use it. And similarly, for example, in India, when Aadhaar was there are now so many barriers on using Aadhaar. And that's where I think that this digital health ID can play a very important role, where at the back end, as Ratan was saying, it can be certainly linked to Aadhaar, but at the front end, at least, it provide a unique ID to a patient. Similarly, unique ID to a hospital. In India right now, in Ayushman Bharat, there is a separate health ID for the hospital ID for the hospitals. In the IRDA Rohini, they have a health ID for the hospital, which is separate ID. Then there's something called LIN by Ministry of Health for public hospital. There's a separate health ID. So same hospital may have 10 different IDs given by 10 different departments or agencies and all. But if you have a unique health ID, it can actually solve a lot of problem in terms of efficiency, in terms of reducing fraud, potential fraud, all these things. So I think that the data which we are generating here in India can be a huge asset, not only because in terms of numbers, but also in terms of the quality. And I think the data is only as good as the quality of data which is being generated. And I think that's where we will need to find innovative ways for hospitals or healthcare provider to enter correct data. Because if you get the wrong data, then you get, garbage in, garbage out, things will happen. So I think that that's where it will be very important to find mechanism, because this is something which is, so to say, not mandatory, especially for the private sector. So how do you engage them? And India still, in spite of everything, 2/3 of the services are being delivered by private sector. So how do you engage them in getting the data of good quality? And that's where I think that it becomes very important that we create systems of necessary incentive and disincentive And once you get a critical mass, then everybody else will pull through. So but we need to reach that critical mass, because then people will feel that they need to be part of it, and then they will make their own effort. And at the last, I will say also the patient should have, and I think this is the part of the ABDM design, that the person should have full power over their data, with whom they want to share, with whom they don't want to share, in which condition it can be shared, all these things. So the person is at the center, and then everything revolves around the person. So I think that in terms of, to summarize, if we have a huge opportunity in terms of getting data, we need to ensure the quality, we need to ensure interoperability, and we need to ensure a modular kind of system which can link with existing systems also, but at the same time which can provide opportunities to the states or to the agencies which don't have their own system, or which have their own system which they want to either change it or they want to just plug it in. So I think it has to be a very versatile system, like API based, or what was being said by Ratan and all, and that will actually help us to scale it up faster, rather than having only one set of system which everybody should start using it, which anyway I don't think is the plan. So I'll stop here. Thank you.
Yeah, thank you, Dr. Nishant Jain. Just one follow-up question I had, because in the previous segment, Dr. Madan Gopal spoke of the fact that if everybody gets onto the Ayushman Bharat scheme, then the capacity for, the beds, etc., is not there. So until now, whatever data has been carried out, is there any sense that we have of how much this gap is, and is there anything being done to build the gap? Because the chief guest, who was the governor, said in Puducherry, 89.8% of the population is now registered under Ayushman Bharat. That's it's a huge number. So like that, if it starts lapping up in other states as well, how well we are prepared to plug in for the demand?
See, I think we have to break this question into two parts. See, what Madan said is important, yes. But at the same time, even if these people are not covered under Ayushman Bharat, whoever is not covered, still if they are sick, they are getting treatment. Some of them may not because of the access issue, financial issues and all, but many of them still do get the treatment. So what happened that the supply cannot change so fast in any country, the supply of healthcare, the hospital and doctors. It's a long-term process. I think government has started these things of converting like district hospital into medical colleges, all these government's new initiative in terms of strengthening infrastructure, setting up new medical colleges and all to nursing colleges. So this will take time. But I think that's where we have to be more innovative. And that's where we have to see that how do we actually, let's suppose if we bring everybody under Ayushman Bharat. Right now also, if you see the data, almost 60 to 65% people are covered under one or other scheme. Only 30 to 40% people are not covered in any scheme, because Ayushman Bharat and the state schemes, like in Andhra, already 88-90% population is covered under their scheme, which is now integrated with, which is now also with Ayushman Bharat. So similarly in Kerala, I think almost more than 50% population is covered. In the states like Karnataka, Chhattisgarh, Meghalaya, almost 100% population is covered. So there are only few states where major population is not covered. So I don't see that the supply, we need to wait for the supply to evolve, then only you start with the demand. So I think it will happen side by side, yes. And when the supply will see that the demand is being generated, the supply will respond faster, both from the government side, but also from the private side. And I think Shuchin is here, so he will be able to put more light on it. But what we have seen in the past a decade or so, that the private sector is very keen to participate in these endeavors. At the same time, they want faster payment, for example. They want that the claims are paid fast. They want that the transparency is there. And I think the Ayushman Bharat and state schemes are doing it. So I feel that the demand and supply gap will be there, but it will take time to fill it up. But at the same time, I don't think it can be a constraint to scale it up. And I think this will happen sooner than later. And there are enough examples from various states where it is already happening, where more than 70, 80, 90% of the population is being covered already under these kind of schemes. And these states have done reasonably well. So I think that I don't see this a major challenge in terms of demand and supply. And I'm quite hopeful that government is anyway doing a lot of things and private sector can fill in wherever is required, and we should be able to do it. Thank you.
Excellent. Thank you, Dr. Jain, because this is again a very important feedback to us in the healthcare space, that seamlessly this can merge the public and private sector for the benefit of all when we are talking about universal healthcare. Last but not the least, first of all, let me thank Dr. Suchin Bajaj for his patience, for having waited to be quizzed and questioned. Suchin is a person who believes where there is a will, there is a way. Otherwise, there are only excuses. He makes no excuses, as how I have seen him through the last couple of years. And being an important player in the private sector, Suchinji, the very fact that last cue from Dr. Jain, if I can pick up, private sector is not obliged to plug in any data for anybody they do, and actually quality regulation, if you so to speak, is nothing strong in the private segment. So, what has been your experience in using the Ayushman Bharat Digital Mission schemes and putting in the data? What has been the barriers in the attitudes and mindset of yourself, of your whole team, of the staff, of the patients coming there? How far have we moved with the public-private partnership issues? Suchinji.
Thank you very much, Dr. Hema. It's always a pleasure to interact with you and take in some of your positive energies, and always your smiling face is a booster for us to go back and work harder. So, see, speaking about myself, we have been very different. As you know, we have been the champions of Ayushman Bharat scheme from the very beginning. We were the first ones to do a cardiac angioplasty under the Ayushman scheme in the country. We were the first ones to do a mitral valve surgery under the Ayushman scheme. We were the first ones to be awarded the golden certificate by the government. In fact, out of the first 10 hospitals in the country awarded that certificate, 4 of them were ours. Because, see, our ethos is very different. Our ethos is that we will not deny healthcare to anyone on financial reasons. Right? It's a fireable offense in our company if you send back a patient because he was not able to pay. We are truly committed to dissociating access to healthcare from financial, social, or geographical status. So, and I think Ayushman was a scheme that was tailor-made for us. All the big hospitals were cribbing about it all the time, and they used to tell me that this has been tailor-made for you. You have had something to do with it, I'm sure. Of course, we weren't. But the good things about the Ayushman scheme, let me speak about them first, because it's entirely digital. That's a very, very positive thing for a government scheme. There is absolutely faceless interaction on claim processing. So there is no need to go and meet anyone or talk to anyone for your claims. Everything is put on the computer and everything is processed there. And especially now with the R.S. Sharma ji's announcement that 50% of the claims will be processed on claim submission, provided you do not have any complaints against you previously. That I think is one of the best things to have come out. The second good thing is claim processing is very fast. We get most of our payments within 15 days. Third good thing is there are no deductions unnecessarily. Everything is package based. So you just put in a package on a patient, and provided you are doing everything correctly, there is no unnecessary deduction. These are the 3 very good things about the scheme. Fourth, of course, is the access to healthcare that it provides to the communities that did not have access. You were discussing about capacity utilization earlier with Dr. Nishan Jain. Indian healthcare, it's not just that it's underserved, and we are the people who are trying to go and serve in the rural and semi-urban areas. All our hospitals are in far out places: Uttarakhand, Uttar Pradesh, Jammu and Kashmir. So it's not like there is lack of service; it's lack of access and lack of utilization as well. India has one of the least hospitalization rates in the world. It's not like we are very healthy, right? It's just that people do not have access to healthcare. In terms of beds availability, we are 155 out of 167 nations in terms of the hospital bed availability. So what Ayushman is doing is providing the communities that did not have access the power to access good quality healthcare. And as Dr. Nishan Jain said, if you involve the private sector into any schemes, and agility and speed is the hallmark of the private sector. I agree, quality leaves much to be desired for now. We are working towards it. But agility and speed is the hallmark, and they do build up capacities very, very quickly to address demand if there is any. The prime example is the number of MBBS graduates and doctors that we are seeing. In 2015, just 6 years ago, we had less than half of the WHO recommended doctors per 1,000 population, and now we have in 2018 touched the number of doctors 1 per 1,000 that is recommended by the WHO. And if you take the Ayush scheme of doctors as well, we have more than 1.3 doctors per 1,000 population, and most of it has to do with the fact that more than half of our medical colleges are now belonging to the private sector. We have various issues with them, of course, which we can discuss at length, but the capacity build up to address the demand has been very quick is what my submission is, and it has been the same with engineering education. You see, most of the seats are now going vacant in the engineering colleges. The capacity build up has been so quick and so fast. So capacity buildup is something that has been an issue that will be addressed by Ayushman. But of course, as going back to everyone else point, if we do not address the primary and preventive part of the disease, this is an endless process that will keep building up capacities, and people will keep falling sick, and we'll keep treating them and doing their third time bypasses and diabetic feet amputation and then prosthetic legs. All of that can be done if you do not prevent diabetes from being complicated by a 50 rupee glucometer test, and making sure that the patient is addressed properly, his sugar is in control, his diet is in control, he has a good exercise program going. If you don't do that, you can keep providing him sick care till he's 100 years old, and costing hundreds of crores of rupees that never ends for even a single patient. So going back to utilizing the data more for primary and preventive healthcare is the way to go, I think, for all of us, and we should all keep working towards it very, very quickly as well.
Suchinji, two quick questions. You said your philosophy is never to turn back any patient because of the financial constraint. Every other private practitioner would turn around and ask, how do you manage that? And that is why they have been, you said, cribbing about the cost, because they say, no, we can't, manage with such small decimal amounts. And therefore, ultimately they all have to get in there. But as of now, that has been one barrier. So you have to tell us your recipe of how you manage. And the second thing is that if there is a hub and spoke model, you said, if the diabetes was treated in early stages, detected early, etc., etc. So what is your methodology as a private practice, many hubs that you have got? Do you see any connect with the digital platform, how you can, offer this remote care so that there is a decluttering and the real ones who land up in your hospital, the volumes are lesser, but they get earlier and better care? Both these, Suchinji.
So, see, the model that we built was built out of compulsion in the early days. We started out when I had no money at all. I come from a very resource-crunched background, and thanks to the Indian government system of medical education, I was able to get through all my studies paying less than 500 rupees a year as my medical college fees. So, when I got out, I've seen the impact poverty has on healthcare access, and the lack of healthcare access that keeps building up the poverty in the communities. More than 6 crore people slip below the poverty line every year just due to healthcare costs in India. So our model is very simple. First, we do not gold plate any of our assets. So although we do very high quality work, of course, we clearly believe that building facilities for poor people does not mean that you should have poor quality there. So you should be very confident that you should be able to get treated there. So many of my family and friends, get admitted to our hospitals. My daughter was born in one of my hospitals. My son has had 2 surgeries in one of our hospitals. So all our hospitals are NABH accredited. We are actually going for JCI accreditation in one of our hospitals now. So the quality is very high, but we do not gold plate any assets. We do not spend unnecessarily. So our setup costs are less than 10% of what it takes to set up a similar NABH accredited hospital in a big city with a cath lab, with neurosurgical equipment, with intensive care, all the works that takes to build up tertiary care hospital. Second, we work on volumes of scale. So most of our doctors In fact, all of our doctors are on fixed pay with a very, very low variable component. So it allows us to do three things, right? Once, because they have a fixed pay, they cannot refuse any patients who are coming in for free. Like, it's a normal reaction of a doctor that why should I get up at 2 a.m. to do this plasty when I'm not getting any money out of it? There is zero fees, patient is not paying anything. So the fixed pay allows us to do that. Second, the fixed pay disencourages and disincentivizes the doctors from any unethical or unnecessary interventions, right? Because they're not getting paid per intervention, they will not do any unnecessary interventions, is what we've seen. And the third most important is, because it's a fixed payout model, once we cross a certain Rubicon, after that, most of the top line starts flowing into the bottom line. As much as 50% of the top line starts flowing into the bottom line once we cross a certain number of patients and a certain revenue per hospital. Excellent. So this model works very well for us and works on volumes of scale, so we can take in as many number of patients as we wish and utilize the doctors as much as possible and sweat out that hospital asset to its maximum capacity. The second question that you asked, if you could remind me, I'm really sorry, I've just forgotten the second part of the question that you had.
The second part of the question was more towards, one was of course how this hub and spoke model.
Yes, of course, the preventive part. Yeah, the digital. Part. Yes, of course. So as I said, we do not consider the exact cost of the disease for a patient very well, right? We don't understand the cost of the disease. As I said, if you treat a diabetic on the very first day and do preventive, the most it will cost you is, say, 200 rupees a month for his medicines and tests. That's it, right? But if you do not treat the patient in time and the patient develops, say, for example, a diabetic foot or kidney failure, the largest cause of kidney failure is diabetes, right? Or cardiac disease or whatever. So if he develops a diabetic foot and we amputate 1 foot per minute across the world just due to diabetes, and he comes to our hospital, we can be very happy in the fact that, oh, we amputated his foot for free, or through the Ayushman scheme, and we saved his 20,000 or 1 lakh rupees or whatever. But we forget this is not the actual cost of the disease, right? Because we've saved him the 25,000 rupees, but he goes home and he does not have a job now because he cannot go to the factory, because he lost his foot. So his earnings, the indirect cost of the disease, may run into lakhs and crores of rupees throughout his life. And the scariest is the intangible cost of the disease, because now he's lost his earning. He will pull his children out of school and they will go to work, and many future generations will be lost. One of my colleagues in our organization who drives a car, and I sit in that car very regularly to go to the various hospitals, he always tells me I was very good in mathematics and I was the first in the races every time till 6th. When my father suddenly died, we don't know what happened. He went to the fields and suddenly collapsed and could not be revived. And then my mother said, now you have to go to work because, your father is not there, so who learns? So he said, I've been driving and doing odd jobs ever since. If his father had not passed away, maybe he could have studied mathematics, or maybe he could have gone into sports or whatever. Maybe he could have been very good at something, right? I mean, I can vouch for myself. My father used to make kites for a living early on in his life. So if he had passed away then, I would be making kites instead of, having been allowed to study all my life and going into medicine, which has a very long gestation period. You keep studying and do not really earn till the time, you're 30, 35. So this cost of disease is very, very important. And this is why prevention is very important. We use a lot of digital methods to do that. We do a lot of outreach camps, and then we follow up with each and every of those patients digitally. We have data of more than 1 million of our patients who have been engaged with us in one form or the another. And we know that we have 170,000 diabetic patients out of that. So we stay in touch with them. We make sure that, they keep follow up on regular basis. We have a large teleconsult program going on. We have a large free medicine delivery program going on. So all of these we do on a digital level, because we realize that, building brick and mortar, although we do have 17 hospitals now, and we have more than outreach free clinics as well. But building this brick and mortar will always have a limitation which digital can surpass very, very quickly in months, what we've done in the last 10 years.
Absolutely. Thank you so much, Suchinji, because it comes across very clearly that we need many more clones of Suchin Bajaj in the country. And I think we are very much inspired by the way to go, go green, they say, go digital, and go the Bajaj way. And I think you proved it to yourself that yes, things are possible. And the very important point that you raised, your better half, Akta Bajaj, has been involved with us for the Janani Helpline program for reaching the right advice to the community pan India. And she and me as OBGYNs would say, every mother, every child counts, but all of us together would say every citizen counts, because it is really for us to reach through digital or otherwise, but in time and ahead of time to do our best. And the next session, which is going to be on NCDs, the non-communicable diseases, as OBGYNs, we always say that it all begins in utero, because it is the child in the womb which is programmed according to the environment in which the mother is. If she is a diabetic in pregnancy, if she has hypertension in pregnancy, if she has anemia in pregnancy, lo and behold, the next generation will have the tsunami of all the NCDs. So for us, the right target is to begin right at the inception of life itself, and as how the life course approach evolves in the infancy, toddler, adolescent, reproductive age, and beyond the womb to tomb concept. I very, very sincerely thank all the very distinguished, very accomplished, and very insightful, meaningful, thought-provoking deliberations in the last 60 minutes, which has certainly given us more than 60 ideas. Idea per minute is, as I would say, Dr. Ratan Kelkarji, Bhaskar Katamneni, Dr. Nishan Jain, and Dr. Suchin Bajaj, on behalf of Kamal Narayan, the entire IHW Council, and the bringing together of the concept of universal healthcare, Ayushman Bharat. Once again, I would conclude by saying Ayushman Bhava and Sarve Janaha Sukhino Bhavantu. I now hand over to Saptak Ghosh from the IHW Council, who will take us forward with the next panel on the NCD care and the benefits to the underprivileged. Namaskar once again, and thank you very much. Thank you.
Thank you, Dr. Divakar, for this introduction. Good afternoon, everyone. Hello and welcome to this very exciting session, that is NCD care and the benefits to the underprivileged. I am Saptak Ghosh from the IHW Council. Well, today, as we all know, at the third edition of the Ayushman Bharat E-Conclave, our entire focus has been on Ayushman Bharat, the world's largest government-funded health insurance scheme, and how for the last 3 years, the scheme has been helping people from catastrophic financial expenditure on account of health. But we also have a flavoring to this panel where we want to focus on non-communicable diseases. In the last 2 years, when everything has been focused on the COVID-19 pandemic, the life-saving vaccines, and of course, the new variants, I equally want us to understand the possible role that the life-saving scheme has played in treating those people, especially those people who suffer from NCDs in India. Well, people who have diabetes, people who have chronic ailments, whether it's related to their cardiovascular system or their immune system or their hepatopathy system, almost all of them have had worse or more stormy journeys during this COVID-19 pandemic for the last 2 years. Well, therefore, we cannot have a conversation of health systems without shedding light on non-communicable diseases. But I firmly believe that this pandemic has been a giant shaking up and a wake-up call for all of us to understand that assistance cannot be done without understanding the fundamental role the non-communicable diseases or systemic disorders play in shaping outcomes for us. And we cannot even go without knowing that. In our previous sessions, experts have deliberated on the successful journey of the Ayushman Bharat scheme over the last 3 years, the digital health ecosystem, and I want to point out there and begin right from there. But before I begin, I would like to introduce our group of esteemed panelists who we are extremely fortunate to have today for this exciting session. We have Dr. Sudip Gupta. Dr. Gupta is a professor of medical oncology at Tata Memorial Hospital in Mumbai. Dr. Gupta is a recipient of the prestigious Prime Minister Fellowship for Doctoral Studies awarded by DSTA-CRB and CII for the course of his graduate thesis degree. He is also an internationally renowned breast and gynecological cancer oncologist and a prolific clinical researcher. Next, we have Dr. Padma Srivastava. A Padma Shri awardee in the year 2016, Dr. Padma Srivastava is one of the top neurologists in India. Dr. Srivastava has a primary area of interest in stroke, vascular dementia, and multiple sclerosis, besides actively participating in the epilepsy program at the AIMS. Our third guest, Dr. Jugal Kishore, who is a noted medical educator and a public health expert. He is part of the development of various departments, particularly community medicine in BP Koirala Institute of Health Sciences in Nepal and the Center for Occupational and Environmental Health at Lok Nayak Hospital in New Delhi. He is also a member of many experts groups of health planning and implementation of the government. Dr. Kuldeep Singh. Dr. Kuldeep Singh is currently associated with AIMS Jodhpur. Dr. Kuldeep has a research interest in the field of imparting medical education, child health, and genetics. His goal is to utilize innovative technology in student learning as well as patient care. Dr. Mohammad Amin. He is noted for his work in establishing technical specification of medical devices for procurement under the National Health Mission. He also leads the work of identification and uptake of innovations that are value in public health programs. He recently represented India at the WHO Global Health Forum on medical devices in Geneva. Well, now I'd like to begin the session with something very critical and something very important. Well, people are thinking that digital health in India will allow for better management of people. However, in our entire rolling out system, we have seen that we still seem to miss out on this early diagnosis for diseases like cancer, stroke. So how do we address this? How do we address this critical aspect? We have this notion of health and welfare, health and wellness clinics. We have primary health centers, but we still don't seem to have a push towards this early diagnosis. So how do we begin to address this? Dr. Gupta, if you would like to shed light on that.
So thank you very much for inviting me to this conference. And since I'm an oncologist, let me talk about cancer. And your question is specifically how to stimulate the early diagnosis of cancers in India. I think that's very important. Some of the common cancers are breast cancer, cervix cancer, oral cancer, and lung cancer. Now, you might know that for 3 of these cancers, namely breast cancer, cervix cancer, and oral cancer, the government of India is already trying to implement across both the primary and secondary healthcare levels methods of screening and early detection that are cost effective and that are locally implementable. So for cervix cancer, this involves visual inspection of the cervix with acetic acid delivered by trained healthcare workers. And in a large randomized controlled trial from our center, Tata Memorial Center, we showed that there was a 32% reduction in cervix cancer mortality with this intervention. For breast cancer in women above the age of 50 years, clinical breast examination, again delivered by trained healthcare workers once every 1 to 2 years. So you don't need any sophisticated technology, you don't need mammograms, you don't need expert readers of mammograms. But clinical breast examination by trained healthcare workers who may be 10th to 12th standard pass, it can be delivered at the primary and secondary healthcare levels, and it is being done as a part of the Government of India's initiative. The third one is oral cancer, and their early detection is by visual inspection of the oral cavity, and again early detection. But let me just, in the next 30 seconds also tell you that this is not primary prevention. This is after the cancer has occurred, you detect it early. So primary prevention means we have to create mass awareness about reduction in tobacco, about the risk factors for breast cancer such as obesity, lack of physical activity, etc., and so on. And for cervix cancer, all the risk factors for cervix cancer, including early age at first childbirth, genital hygiene, and others. So I think, the strategy has to be multi-pronged, both at primary prevention as well as secondary prevention or early detection and screening. So that's what I need to say.
Dr. Gupta, I have a follow-up question for you. That is, you spoke extensively about the cancer, the prevention, the strategies we need to have, the multi-pronged strategy in particular. So I would like to ask you that when you talk about Ayushman Bharat scheme in particular, like how has it been beneficial to people who suffer from NCDs in particular?
It has been extremely useful. And because I work in an exclusive cancer hospital, I'm not an expert in, I will not be able to tell you about other diseases, but in cancer, it has been extremely useful. So we have packages for multiple common cancers that occur in the Indian population. And most of the curative treatment of patients ranging from stage 1 to stage 3 cancers for almost all cancers can be delivered within the Ayushman Bharat schemes. And a large number of patients who belong to the underprivileged sections of the society are benefiting in our hospital and in hospitals across India. And I might tell you that now Ayushman Bharat has tied up with the National Cancer Grid, which is an initiative of Tata Memorial Center, and new treatments that are evidence-based. So you see, we can't introduce into Ayushman Bharat anything that comes to our head that this should be delivered on a population-wide basis to all cancer patients, because as you know, some treatments are extremely expensive and not very cost-effective. So now there is an evidence-based introduction of new treatments that are useful, that reduce the mortality, that increase cure rates into the Ayushman Bharat. And in our center, a large proportion of our underprivileged patients are able to benefit from these treatments. And also not only in our center, but across all centers in India. I know for sure that many different hospitals that are enrolled in the Ayushman Bharat scheme are able to deliver those treatments.
Thank you, Dr. Gupta. I would like to come to Dr. Padma Srivastava now for her opinion on this. So Dr. Srivastava, you are a stalwart in stroke and have been an expert in NCDs. So I'd like to ask you a very straightforward question. That is, how do you see, what do you see the current scenario as far as NCD is concerned in India? Like, we have a lot of focus right now on COVID-19 pandemic, the vaccines in particular. So when you talk about diseases like stroke, cancer, and other cardiovascular issues, so where do you see, have these issues been put on back burner, sort of back burner, and or do we still have a solid focus on these diseases?
Thank you, Mr. Ghosh, and thanks once again for the kind invite and be able to connect with you all. So let me answer this in a little bit one step back, that you are well aware of the 2017 publication in Lancet Neurology, which sort of, in Lancet, which actually gave you the state-wise disease burden across the country over a period of 26 years. And the massive shift from non-communicable to, the NCDs, which got big focus, more than 53% increase as against the communicable disorders. So, and in that, the big five are what you're targeting now, whether it is cardiovascular, stroke, cancers, pulmonary, and the kidney diseases. Said that in the northeastern part of the country, stroke is the #1 cause of death and disability for reasons more than one. And if we are talking about the statistics, they're so humongous, like as we speak now, there's a stroke happening every 20 seconds in our country and one stroke death every 2 minutes. And this is our own statistics from Indian Council of Medical Research and Ministry of Health. That said, it is true that with the COVID pandemic, as you said, in fact, this whole era is probably now rechristined. It's no longer AC and BC. It is after Corona and before Corona. So there's so much of learning which has gone into in all aspects of life, whether it is health and what have you. Said that, it is true also that this is published data across the world and also from our own country, that the strokes just sort of diminished to appear during the lockdown and in the first wave, but then they got picked up, and it was a lot of reasons why they could not reach out in time. They were happening definitely, and in the last year's stroke, the numbers have been published now. We had 18 lakh people who had stroke registered in the country last year, and that is during COVID. And the most important thing out here is that 25% of these strokes have happened to people who are less than 40 years of age. That is stroke in young, which is extremely concerning, that this is also the biggest cause of disability. And that's the biggest bugbear we have. So said that again, the impact of COVID-19 on non-communicable disorders with a focus on stroke has been one, as you're going to prevent, as has been rightly pointed out, whether we're talking about primordial or primary or secondary prevention, and you're looking at vascular risk factors, which includes diabetes and hypertension, everything took a back burner. No one even really had an access, applicability. They were not even looking at, the survival was from day to day. So they were not looking at their controlling of blood pressure and blood sugar. There was no handheld programs to ensure the compliance, reach out to get the medicines. So everything was centered, and all the medical healthcare facilities of delivery of healthcare was all COVID. Rightfully so, because that was a focus. But so there's a whole lot of problems which has happened to NCDs, which are now people are looking at. So there's a big chunk which needs to be looked into, because over a period of 6-7 months, when these risk factors are not being looked into, plus the post-COVID and long COVID, which also has impacted development of new diabetics and everything going haywire, and a lot of strokes which have happened again, COVID and long COVID. So now we see a huge emergence of these coming back. It's like a surge back. And so that is there. So it's a double whammy for especially the developing world, which was dealing with communicable diseases, shifted to NCDs, and now we have a double whammy of both coming back. And hence there is a lot of pressure on I think both the infrastructure and the delivery. It's not an easy task, but with champions like you out there and all of us together, we can deal with it. But now we getting the stats right, so we can deal with that.
So a quick follow-up question. It's a very important insight that I've shared with us and our viewers. So a quick follow-up question to you is that what do you think the role of Ayushman Bharat scheme will be in addressing these NCDs? Now that there is a huge surge, we have, sort of going down in addressing these NCDs, given our entire focus is on COVID. So how do you think a universal health coverage like Ayushman Bharat will play a role in this?
See, the healthcare system and healthcare delivery in India has always been hierarchical, in the sense where primary, secondary, and tertiary levels of delivery. So the primary level, the wellness clinics, which is a focus there is prevention. So it is maternal and child health, is immunization, the risk factors, whereas diabetes and hypertension. So it is essentially a primary preventive module. The focus is on ASHA workers and other, primary healthcare people who are not necessarily trained medical personnel, but you have to get in as much as trained professionals. I would say professionals, even if it is 12th class, because they're trained personnel. Rather than believe that you will have around 3,000 neurologists to take care of 1.3 billion population counting. We may be adding another Australia to us in the next couple of decades. So that's never going to be equalized. So you're getting stroke physicians, and we have these trained personnel who will be built into the ground force to have the same outcome. So in that, the wellness clinic and the primary health would be preventive modules. So wherein the Ayushman would come into the preventive module, and that's already well established. This has been there for a long time now. So it is provision of those important infrastructure, like you have a point of care, you have a glucometer, you have a blood pressure modem out there, somebody to monitor, somebody to tell you, and those algorithms that please do this, and awareness programs, as you said, pick up early, pick up those strokes and the red flags so that they can be referred. That's there in the primary. The tertiary is where we have empowered. So right now with the Ayushman, we have the physicians who are managing the emergency healthcare who are able to manage acute strokes. And this has been there. This was first established, published literature in Himachal Pradesh using a even this was just pre-COVID, we used WhatsApp models, which is our model of telehealth, which is low cost. You see, you need to tweak the systems, low cost, India-centric, region-specific, in which Ayushman will be a huge shot in the arm, because this is a top-down, and it is the government is empowering all these thought processes and implementation processes. So it is absolutely essential, and at district level, the cost of an acute stroke care is being borne out. So, you are inching towards this policy of health is my birthright. Health is like a responsible citizen in a civilized society. Health is my birthright. It can't be bartered to haves and have-nots. So it's not a luxury. So I think that's what is happening. And in a ballgame like a stroke or an MI or a trauma where every minute counts. In fact, the theme of the World Stroke Organization this time is minutes save lives, the time save lives, every minute counts. So in that, it is Ayushman and the assurance that my acute care, I don't have to shell out. That thing is there, it's being taken care at a district hospital level. I don't have to go to a high-end tertiary care and reach out to a super specialized neurologist. That's what Ayushman is doing, and also into the tertiary care center. So I think it is like a blessing.
Thank you so much for your important insight. I would like to come to Dr. Jugal Kishore. Dr. Kishore, so we have so far listened to the opinions of two eminent panelists we have today. So I would like to ask you something. That is, so what do you think are the challenges and the need to improve, and how do we need to improve the penetration of Ayushman Bharat scheme in covering this, in bridging the gaps that we are witnessing so far in our coverage of NCDs? I think you are on mute, Dr. Kishore.
Thank you. Thank you to you and also the council. I just want to say, do you have data, or we have data on most vulnerable group? You have talked about this vulnerability, but I'm interested to know. We have the vulnerable group like the scheduled caste, scheduled tribes, slum population, OBC. Where is the data? Where is the Ayushman Bharat? Any kind of program is saying that this is the number of people are benefited. We have many policies and programs, but when we see the real implementation, we find the reality at the ground level. Whatever you say, yes, this is very good that we have health and wellness center and the Ayushman Bharat is covering. But the amount of the interventions provided or should be given to the rural area or to urban areas in periphery is actually very less. It is screening. Screening is not regular. If you talk about the ASHA worker, whom we are focusing on, and everybody's talking about it, how many ASHA workers are actually doing the blood test and measuring the blood pressure level, and do they know and do they have time when we have huge amount of work on RCH component? They don't have time, and how much money you are giving to give all the activities. So we have problem, but at the same time, yes, it's a good initiative, and there is a link of periphery to, or say, the first primary level to the tertiary care level. But unfortunately, when we say that the number of AIMS, are now established in the country is more than the number of primary health center is established in the country. The number of primary health center is same, or maybe sub-center is same, 1,24,000, and that sub-center is now converted to health and wellness center. If you want to increase the number, then you increase the primary health center, also convert it into health and wellness center. So that conversion is not going to solve the issue. It is to increase the number and reaching to the most remote area where you can provide the health services. So issues are many, and unfortunately, things are not at that par. The frontline worker, you say, ASHA worker, I think we require extra manpower over there, and that can look after the non-communicable disease and should able to handle all these things. We already know it is not a new thing. We already know that India is facing triple burden of disease, not even double burden of disease. So, and that is almost 20 years we are talking about that it's a communicable disease. It is not that a new pandemic has come. Every time we are facing, and India is never gone, without communicable disease, not even a single. And COVID has, exposed the most, fabric of our, this health system. And at the same time, we say that we don't have any number of cases of non-communicable disease has gone down and then start coming up. Actually, during this period, all the COVID deaths are because of the, non-communicable disease. They all died and they are not measured. They are labeled as COVID deaths. So anyway, the point is we have long way to go, and this program require strengthening and real, target on the issue, which is that yes, if you really want at the sub-center level, health and wellness center, which can be a very good thing if we provide good infrastructure, which is not there, still not there, and health worker. The health worker, extra manpower, it is not the ASHA worker who is going to do it. So maybe I think we can do good thing. And then linkage between there to the community health center. It is not directly to Tata Memorial or to AIMS. It is not possible. We have to have, community level center where they can manage many things. And remember, the health delivered by all these big hospitals is just 2% of the total. The rest of the things are somewhere else, not even health. It is beyond the health department. There are many things, factors has to play a role. So yes, we should recognize from where we are getting the help, and that should be given weightage to it. Should be recognized and also be cherished. So till we are not, accepting it, then I think we are not going to solve this problem.
Okay, so I'd like to ask you something. So a quick follow-up question to you as well. So given that we are, sort of tied with so many challenges, so many constraints, so many possible, like, I'd not say it's a setback, but there are always room for improvement. So are you hopeful of a radical shift in the next 2-3 years, or maybe 5 years down the line, that the scenario will eventually improve and we'll have everything in place?
I mean, a government setup, I cannot say no. I have to say yes. But yes, we have huge challenge. Till we are not recruiting, like even ASHA worker, they are not happy. They are having the alternative day, the strike, that they want regular pay, regular, service. So we are asking a lot of work from the people who are not stable themselves, So we have huge challenge, and we have to make some kind of strategy which can have the stable system. It should not be ad hoc project based system. We require strong system. So then I think I can feel that yes, things will change.
Thank you so much, Dr. Kishore. Thank you so much for your insight. I would like to come to Dr. Kuldeep Singh. Dr. Singh, a very warm welcome to our session. And so far, we have had some critical insights and critical, our experts have shed lights on some of the critical areas where we need to focus. They've also spoken about the possible challenges, possible constraints that we just heard from Dr. Kishore as well. So your thoughts on this?
I agree with Dr. Padma and Dr. Jugal Kishore that now the world country is facing not only a double burden but triple burden. That is, we are still having the communicable disease, and to add to that is the non-communicable disease. And now we are also preparing for the future of the disease, which are like obesity, cancer, and also genetic disorders. So with the control of these infectious disease and the other common non-communicable disease, we are going to face the challenge of the non-communicable disease in the form of genetic disorders. And these are going to become a major chunk in the future. Both in all the systems of the body may be involved. right from the like neurogenetics to the cardiogenetics to the renal and other musculoskeletal disorders. But the thing is that Ayushman Bharat is one of the ray of hope. And I agree with Dr. Padma that when she said that the prevention is more important. So here we should focus more on the health and wellness centers. And one of the component of the health and wellness center is education and awareness. And what we have observed with our multiple projects, that if we can provide this through the help of the school health education, that is adolescent is the period where we can target these individuals, the girls and boys both, to prepare for the future. So unless until they are prepared to take care of their own health, they should not go for their offsprings and other things. And when they are prepared for take care of their body and the if the girls are prepared to take best care of their baby inside the uterus, inside the womb, then they are well prepared to take the litter also. So I think this health and wellness center is a good concept, although it encompasses the screening program also. Right now I am sitting at Sirohi, Abu Road, Sirohi. So it is a tribal center where we can do much of the work. So I think many of the government organizations as well as the corporates and the district hospitals, they can join together and converge to provide the scheme. But I also agree with Dr. Jugal that there is ASHA workers are most overworked. So we have to need another set of cadre who can be trained to provide the screening services, holistic approach, support services, and also for the promotive health. That is very important.
Thank you so much. So I just have a quick follow-up question to you. That is, so do you think that the management of non-communicable diseases should be more robust in terms of identifying, detecting these issues that such a kind of balloon in the near future?
Definitely. And I agree in this aspect with Dr. Jugal Kishore that there is a need for strategic planning. And strategic planning should be so robust that it should take into account the national health policy and what is the concept of the Ayushman Bharat. And based on that should be taken as the base on which we have to build a robust system of tackling these non-communicable disorder. It is not just asking the healthcare workers who are existing to provide the non-communicable disease, because screening for this program is not so easy as we think. It requires more investment in the part of the time, money, and also the other resources. Because unless until we have the facility to screen them with the help of point-of-care devices, and also to take care of if the diagnosis is made. So there is a need for taking care of the screening program who are at risk. They should be offered a confirmatory diagnostic test. And also one thing very important, Dr. Jigal Khushar has mentioned that we are targeting right with the existing health worker, a very small portion. I would like to say that if the person visits an hospital, that is only 20% of the problem. Rest of the 80% of the healthcare problems are existing in the society, for which we need a more robust system. Definitely.
Thank you so much, Dr. Singh. I would like to come to Mr. Mohammed Amil. So, Mr. Amil, so what are the possible ways, if I may ask, what are the possible ways so we can, we have heard so many opinions, suggestions, and learnings from the esteemed panelists so far. So what do you have to say on how we can manage the growing incidences of NCDs in India?
Thanks, Mr. Ghosh, for your question. Actually, all the good points have already been covered by such an eminent panelist. Not much left for me to add on, but I'll still make an effort to do so, having worked with the National Health System Resource Center in my previous role, which is pioneering the comprehensive primary healthcare program and setting up health and wellness centers. And I think a lot of efforts has been made in that regard already. And I would perhaps want to reiterate some of those so that people hearing this are well aware of that. So despite our economic strength and growing global structure, we face multiple challenges in health, and crores of Indians get pushed below poverty line owing to catastrophic health out of pocket expenditure. And we know the burden of disease that you specifically mentioning is other than that, one of my fellow panelists also mentioned that it's threefold, not only communicable, non-communicable, but diseases beyond that as well. And so we have to tackle it with a very comprehensive view, and that's what the comprehensive primary healthcare program is trying to do. And we believe that that's the route for achieving the universal health coverage. And tomorrow, rather day after tomorrow, is the UHC day to celebrate that. So in order to tackle all this, in 2018, Ayushman Bharat, the largest flagship scheme of India, accelerating India on the path of universal health coverage, was launched. And it has been a game changer for the poor and vulnerable population of the country. So it seeks to meet the national health policy goal, which says the attainment of highest possible level of health and well-being for all. So well-being is very important, and at all ages, through a preventive, promotive healthcare orientation in all development policies, and universal access to good quality healthcare services without anyone having to face financial hardship as a consequence. So this ensures improved access to and affordability of and lower the cost of healthcare delivery. So the scheme focuses on the need to address the high and increased burden of NCTs. And as we said, the government has established health and wellness centers across India to provide this comprehensive primary healthcare, and also to deal with NCDs along with communicable diseases as part of Ayushman Bharat. There has been a striking increase in prevalence of heart disease, strokes, and diabetes, high blood pressure, high cholesterol, cancer, as some of our fellow panelists just mentioned. And specifically, the PMJY scheme under the same umbrella of Ayushman Bharat, which is fully financed by the government, provides a cover of 5 lakhs per family per year for secondary and tertiary care hospitalization across public and private empaneled hospitals in India as well. So over 10 crore poor and vulnerable entitled families, which accounts to approximately 50 crore beneficiaries, are eligible for this benefits, and the scheme envisages to mitigate expenditure on medical treatment. So the vulnerable population of the laborers, the tribal groups, the rag pickers, the domestic workers also get a lot of benefit of this, apart from the others which fall the category of below poverty line, are all covered under the scheme. So so it starts with the screening of the common cancers, the cervical cancer, breast cancer, oral cancer, and hypertension and diabetes, and continuum of care is ensured with secondary and tertiary care, as I just mentioned. And some of our fellow panelists have already mentioned what are the methods being used for those screening. So VIA for cervical cancer, and for oral cancer, it's again visual inspection, and breast cancer, the clinical breast examination and self breast examination methods have been used. So yeah, so this is it from my side. Thank you, Ghosh.
Thank you so much. Dr. Gupta, I have a question for you. So I was recently going through a research paper published by the NHA. So according to that NHA working paper which was published in the month of February this year, it says that 17% of all beneficiaries travel within their state, and 2.4% of all beneficiaries travel across states to avail service for breast cancer. So do you think the portability of PMJY packages can help in universalizing the treatment of cancers?
Yes, currently you are right that patients do travel to many institutions that are outside their state, even across many states, because the availability of expertise and resources at the tertiary care level is not evenly geographically distributed within our country. So for example, in our own institution, Tata Memorial Center, we register close to 60,000 new cases every year, of whom about 2/3 are from outside Maharashtra. And a large proportion are from the northeast, from the north and from the east part of the country. Much fewer from the south of India, because healthcare services are relatively better developed there. So yes, portability of these packages will help. Definitely.
Okay. Yeah. So
can I just add one thing? You know, I'd raised my hand. I just wanted to say, I think Professor Jugal Kishore and others have correctly pointed out the many challenges that still lie ahead despite Ayushman Bharat and many other initiatives. But I just want to say that, you know, challenges of course remain and there is a long way to go. India spends only about 1.26 or 1.3% of its GDP on public health compared to many other countries. But I still feel that the big picture is that we are much better off than we were 10, 15 years ago. And I will give you, you know, so you know, we should, sometimes it is good to be critical, but we should not lose a sense of the overall direction in which we are headed. I myself know that about our own data that was published in 2011 showed that 93% of our patients did not have access to a life-saving drug for breast cancer called trastuzumab. You know, it's a treatment for HER2 positive breast cancer. It is published. Now in 2020, close to 100%, if not 100%, let's say 95% of the patients, not only in our hospital, but across India are able to access that drug. And it is truly a life-saving drug. And, you know, this has been possible largely because of Ayushman, I mean, not just Ayushman Bharat, but many different state governments also have their own initiatives in being able to help patients in secondary and tertiary care. So a lot of challenges remain. I'm sure the ASHA workers can be much better off. They can be paid better. Their working conditions can be made better. There can be more of them, etc. and so on. But still, I feel that India is making progress. And I think we should be cognizant of that fact as well.
Yeah, so also once again, so another question to you is that you just pointed out about the geographical disparity which we have in ensuring that cancer care patients, you know, cancer patients get better treatment and coverage as well. So how do you think that with the advent of, you know, Ayushman Bharat digital mission, which we have, so we through our digital ecosystem will be able to cover it more better than it was before?
So you see, there are two aspects to it. One is to provide resources to the underprivileged sections of our society so that they can access healthcare. But the second part of the equation is that the facilities to provide that healthcare should be available. So, you know, if you look at certain states in northern India, for large populations, they have much fewer, you know, facilities for treatment of all non-communicable diseases, particularly acute care and subacute care like cancer and stroke and others compared to certain other states. So yes, the Ayushman Bharat, PMJ, etc. has to happen. But also, you know, there has to be public-private partnership. But I also feel that health also is a fundamental basic human right. And so therefore, there needs to be more government buy-in into health. And, you know, we need to allocate more proportion of our national income and our GDP into health and to create actually the infrastructure to deliver health. So, you know, unless you have secondary and tertiary care hospitals, we will not be able to deliver health. And, you know, you can't expect a person from Bahrain in Uttar Pradesh to travel to Bombay or to Delhi for I mean, they are traveling just now, but ideally it's not a very ideal situation.
Okay, thank you so much. Dr. Padma, so if we focus this on stroke, from shifting from cancer, so what do you have to say on that? Like, what are the scope of innovation that should be integrated into PMGY packages for stroke care going forward, especially in the post-COVID world?
Okay, so one is that, let me just get onto this innovations part of it. Just as Dr. Gupta has said, 2014 and before, in the state of Himachal Pradesh, ever since the thrombolysis for acute ischemic stroke, which remains the mainstay, it's a blocked artery, you need to unblock it. It's no rocket science, it's no brainer. You understand that to prevent the damage. So that didn't happen. And in 2014, the first thing that had happened was that we made this drug free. The government of India did it. You can't go around rushing for the medication, and the medication costs money. So it's not few hundreds, and you don't have time to run around for that. So that pharmacopoeia was there in district hospitals. Himachal has 12 districts. There are 2 districts which are, completely mountainous. It's difficult to reach. There are 10 districts. The workhorse is CT scan. I'm a strokeologist. I know the amazing advances in stroke management, but the workhorse is just a plain CT scan. That the basic minimum infrastructure, that when a stroke happens, and let me get back to you again on this, that even in big urban cities, the stroke care is not equal. It's different across one particular state. You turn left, there is stroke care. You turn right, even in public sector, there's no stroke care. The stroke care is not just a stroke unit and rehab. You need to unblock it because time saves lives. And that was possible in the year 2014, free of cost to every person there. And it was given by an orthopedician, because that empowerment was given to the physician who was managing the emergency care, whether it's a delivery, it's a road traffic accidents, it was a heart attack or a brain attack. Now that's the paradigm shift which has been brought out, and that's what Dr. Gupta was also saying, that we are looking at positive changes, but a long way to go. I completely agree with Dr. Kishore on this, that we have a long way to go. We have really big miles to cover, and we can't rest on our laurels. True, we need more empowerment, but that's been one. That you have shifted the focus to the, in an emergency care, empower the emergency doctors. Not, just say that they're super specialists. Number 2 is get that relevant minimum infrastructure to deliver the care. Number 3 is that, there is a disability, and stroke is one of the biggest causes for a disability. Then you say, okay, go do some physical rehabilitation, go and do physiotherapy. Now that's not going to be an answer. Both, it is expensive, logistically, it is just not happening. So what did we do? We're developing low-cost intervention techniques. Now, let me tell you, Mr. Ghosh, there are few crores worth robotics which are available in the other parts of the world. Would that be, applicable to my country? It is neither to me nor you. So we are actually integrating different sciences. But we partnered with biomedical engineering in IIT Delhi. There's similar such networks across the sciences which are coming together to develop solutions which are low cost, India-centric for these focused areas. So the first is, as Dr. Kishore said, map out your challenges. Number 2, make solutions which are region specific and India centric, which have to be low cost. We don't have that kind of money. Number 3 is empower the networks with the available infrastructure. And yes, we also need to incentivize our healthcare workers so that they're given that kind of an impetus to work. If you don't, then it's going to fall apart. So I think the advances, whether it is pre-COVID, post-COVID, whatever the challenges we need to map out, the challenges are going to be a little different, but they would be really the same. And map out what best can be done with our relevant available stuff that we have. And one thing we have plenty is our human resources. So I think we need to, really build on those part of it. We truly are a lot of people, and it has to go beyond super professionals and professionals. It has to come down to training personnel, the minimum training required to deliver those challenges. I would think those networks need to be developed.
Thank you so much. Dr. Jugal, if I may ask one question. So you, in our interaction, you deliberated upon the challenges, the constraints, and the roadblocks, the bottlenecks we have. So if I may ask you, what are the various steps that the government and the healthcare fraternity must undertake to spread awareness, provide help, and facilitate mitigation in the rise of NCDs, especially in the regional level? So as we all know that communication is key, but do you think there has been a lack in communication so far? So, that has been lacking, and do you think that should be, zeroed in right now? Dr. Jigot, you are.
Ghosh, you rightly said that communication is the key, but we have many studies showing that when we look at the rural area or maybe some even urban areas, And recently we have National Family Health Survey 5, where the anemia has increased. Then, it should have been, although we have obesity going up, so one can easily say our nutrition value is going up. People are taking a lot of nutrition or a lot of energy, but at the same time, the quality of, food is very poor. Similarly, in case of NCD, you have information, but that information is useless or maybe creating problem. Otherwise, this whole thing would have not been there. So we require an appropriate, communication policy, programs of educational awareness program, and what Ayushman Bharat or maybe I think Health and Wellness Center we are talking about, is still, we require again designated staff or cadre where awareness can be a separate, wing. It cannot be like, merged with that Asha will do everything. That is what we are looking at, that she's the primary healthcare worker. So she has to disseminate this information, but this is not the way. So we need to develop these all things, and we may require, I think IT people to be part of it, and we have many innovations and can be done through them. So multi-pronged strategy where many sectors has to come together, and yes, non-communicable disease is a, but we have relationship between communicable, non-communicable, and also, the population. So in one way, just looking at non-communicable is not going to solve. We have to see that how TB is linked with, diabetes and HIV with other infections. And now the COVID is showing that COVID communicable disease can devastate everything. And you cannot forget the communicable disease. And then it leads to so many non-communicable disease. The long COVID is a witness that you cannot separate them out. So we have to have the comprehensive policy of awareness. And in the end, I just want to say that, although we talk good things, but, when you are from institution like the Safdarjung Hospital, which is a central government, or maybe AIMS, people will talk good things. But if you include some of the panelists from Northeast or maybe Orissa, or maybe they will tell you the real picture of the country. And as Dr. Gupta has already said, that our allocation of fund is just 1.3. And I'm writing, national program for last, 20 years, and I'm aware of the public health spending. So last 30 years, it has not increased. And rather, I'll say for last 50 to 60 years, we have not increased this expenditure except, minor changes of up and down. So that's the biggest one indicator in the country, which shows that how much you are really interested in public health. That's what I want to say.
Thank you so much. My last two questions will be, I'd like to begin with Dr. Kuldeep Singh. Dr. Singh, how do you think smaller health centers, especially in rural areas, can address these challenges? Because in many rural areas where the internet penetration is low, or the communication is as Dr. Jugal just pointed out, communication is lacking. So how do you think we can get this sorted, especially in the rural areas or in the hinterland?
Yeah, this is very important, like considering the regions which are located in the rural area, because most of the facilities are developed in developed cities and developed centers. For example, AIMS are also created with the intention to bridge this gap. And I am right now sitting in district Abu Road in a Janjati Bhavan, where we are providing the telemedicine services. And we are having a just review meeting about how we can go about. So this is a topic which is being discussed here also. And I think innovation is the buzzword nowadays with the post-COVID. And innovation is required not only for like screening or point of care device or some other methods of program implementation, but also for taking the integration with the health services which are existing. And innovation is also required in the education area. So when we talk about the education, we just talk about the numbers. Whether it has any impact on the skill development, we never talk about. So that is also very important, that what is the impact of our educational interventions? And we are now talking about the hybrid system, blended learning, I think problem-based learning. These can be implemented right from the beginning in the schools. And the focus should be on the more of the intelligent use and utilization of the available resources, rather than creating or longing for a very huge investment in this area. So some small investments, innovations can tackle 80% of the problem which are existing in the society. Like communicable diseases are very common, and for that education and awareness will bring about the changes. And for communicable disease, non-communicable disease also, this is very important that we offer them the educational awareness. Awareness not only form of lectures. Lectures are not enough. We have to devise some innovative method to change their behavior. What is Sweden is doing is that they are using the nudge theory, that is behavioral economics theory. In the behavioral economics theory, they bring about the behavioral changes through the education, through nudging. They are not forcing anybody to adopt something new, but they are just nudging, they are giving options. And so similarly, we can give the best option, which is going to improve the health of the society. So I think using the existing national education policy, national health policy, existing health infrastructure, we can augment all these things into the better health services in the area, especially in the rural area where the internet penetration is poor. But again, we can use the blended learning platform in which the education schools can be used for imparting the skill, and their impact can be seen with the physical face-to-face learning and interaction. That is what is my take.
Okay, thank you so much, Dr. Singh. So my last question would be to Dr. Amil. Dr. Amil, so I would like to deviate from what I've asked so far and focus on something important but not related to the NCDs. So, so if I may ask you that many in India are still wary of a digitalized health ecosystem owing to data privacy concerns. So do you think, how do you think this can be addressed going forward in addressing both the non-communicable diseases and communicable diseases?
Thanks, Ghosh, for your question. I think Government of India has given a lot of impetus for Make in India already. And especially in the health sector, if we see there are multiple subsectors which need focus, be it medtech, the pharmaceuticals. We are anyways called the pharmaceutical capital of the world, but APIs is something which need further elaboration. And then you mentioned about data privacy in terms of digital tools, because a lot of brain drain is happening from our country in digital world already, and we have been a forerunners in the IT platform for the past decade. In the health sector as well, a lot of impetus has been there on digital health as well. And if you see within the Ayushman Bharat program, the National Digital Health Mission, who is one of the most important pillars, which is going to change the way how we operate in the health sector with health ID. Health ID is being generated even with the CoWIN platform for every one vaccinated. So if you check, most of us have started getting health IDs, although these are yet not unique. And by this, you are able to actually ensure data privacy as well, because you are not making this ID unique, one ID unique to one person. So every time you get into this, you generate a health ID, there is a a very good mechanism of ensuring the data privacy is not hampered. Also, there have been a lot of recently papers also which are under consultation, which ensures that the patient data is not at all compromised, and once it utilized, it is utilized for the best use for patient history and for taking better decision making, and not actually used for any sort of malpractices. There's one important paper also being circulated for consultation by the government of India, which has a specific focus on ensuring and there's a public consultation going on where people can contribute and give inputs to on health IDs and patient data going forward. Unfortunately, I'm not able to recall that specific name, but I think we should be able to get that once I've given a hint on that. So over from my side. Thank you.
Thank you so much. So as we're about to close this exciting session, it has been nothing short of a very enriching and very educative session for me as a person, as a public health enthusiast as well. So I'd like to thank all of you for joining your critical inputs on insights on NCDs and what are the possible key takeaways, key learnings from all, and what are the possible roadmap ahead for India as far as addressing NCD is concerned. So I'd like to thank all of you. So my next session, which is equally an educative and enriching session, is on effective and strategic communication for mass penetration, and it will be moderated by Mrs. Kavita Devgan, who is a writer and author by profession. Thank you all. Have a nice day.
Thank you.
Thank you, everyone.
Thank you. Thank you, Mr. Ghosh. I will
Thank
take
you.
over. Yeah, I will take over from here. And I was listening to this very interesting conversation, which was happening, and it was quite an eye-opener. And now we move on to the next level, for which I'm here with my set of very esteemed panelists. So good afternoon, everyone. I'm very, very happy to be here today to lead an important discussion that we have lined up for you. This is on the importance of effective and strategic communication for mass prevention. Now, our aim today is extremely simple and straightforward. It is to create public awareness to help people understand the importance of the largest health scheme in the world. Yes, I'm talking about the Ayushman Bharat scheme, the world's largest government-funded health coverage. So with the help of a very distinguished set of panelists that we've lined up for you today, our aim is to highlight some of the scheme's very innovative ideas and case studies. And basically, the whole plan is to ensure that its reach reaches as wide as possible. Thankfully, via the people who are listening to us, and also to the people they would have access to. Now, India has run many population scale immunization campaigns over the years, extremely successful ones. One prime example of which is the extremely successful campaign run to eradicate a very deadly disease like polio. However, this success did not come about overnight, as we all know. Along with the blood, sweat, and tears of the doctors and the frontline workers and everyone who was associated with the scheme, the push to vaccinate every child across the country was powered behind the scenes by an extremely effective and strategic communication that delivered the key messages across the country and made the scheme so successful. From the governments to the non-state actors, everyone played a role to ensure that the key messages of eradicate polio spread like wildfire across this diverse and huge country that we live in. And the message thankfully reached the common people, making it an extremely credible communication strategy and a process that was done in an era where internet was still a distant dream in India. So in short, today we know that the effective communication campaigns about the oral polio vaccines played a very, very important role in helping India become polio-free. In 2014, 20 years after the launch of the ambitious Pulse Polio program on October 2nd, 1994. When the Ayushman Bharat scheme, the world's largest government-funded health coverage, I love to repeat that, was first rolled out, it remained an elusive dream given India's Byzantine and complex healthcare system. While in the first year, 47 lakh out of 53 crore vulnerable families benefited from the scheme, data reveals now that over 19 crore people have already benefited in its third year, including tens of thousands of COVID-19 patients during the ravaging months of the pandemic. Today, many Indian states are gradually implementing the Ayushman Bharat scheme, which is such good news, and the steps taken by the government of India to deliver the key messages of this life-changing scheme to people are indeed commendable. So, my question is this another brilliant example of an effective and strategic communication exercise that can help ensure improved access to quality healthcare to the marginalized Indian citizen? Let's ponder over this one. And to discuss this in detail, I'm delighted to introduce the panelists that have joined us today. Mr. Ajay Maharaj, Head Corporate Communications and PR, Fortis Healthcare. Welcome, sir. Dr. Narayan Sinha, State Consultant, Ayushman Bharat National Health Mission, Department of Health and Family Welfare, Government of Chhattisgarh. Good afternoon, sir. Mr. E. Kumar Sharma, Deputy Editor, FE Digital, the Indian Express Group. So we have a wide set of experts across the disciplines to discuss and ponder over this important question that I've put up today. A very warm welcome to all of you. Let me begin with Mr. Ajay. The Ayushman Bharat scheme recently completed its third year. And going by the data, it seems that many people have finally gotten to know that the scheme really exists. Did the online and offline communication campaigns carried out by the government prove timely to reach the hinterland? Please, could you share your thoughts on that?
And thank you very much. And I think an excellent initiative by the government for sure, in which they would like to help out maximum number of people across the country with a wonderful scheme, and which was a very much required scheme. But I think the COVID played a big role towards like people becoming more and more aware about the scheme also, because of the COVID, so kind of hospitalization, the kind of medical treatment which everybody required was extremely, extremely crucial for this scheme to become more and more awareness towards getting more awareness in the public domain. So and like what you talked about, the polio eradication, that what the government has initiated and the way they have implemented it across, I think this is, and I think it's taken a few years for them to succeed in that. But looking at the population of India and the kind of territorial differences and the kind of set of people what we have in different parts of the cities and the countries, getting it across to each and everyone is going to be a big challenge. But I think the government is well equipped, and the way they have progressed with different schemes, they will be able to deliver and ensure that each and every citizen can avail this wonderful scheme. So I think it's going to be a success one, and government has done a great job in introducing such a wonderful scheme for the people.
Wonderful. Sir, if you could add, I have another follow-up question for you. How effective do you think Government of India's capacity building programs and information education and communication guidebook IEC. Yeah.
There was some issue with my network. Can you just repeat the question, please?
Oh, sure. I basically had a follow-up question for you, sir. I just
Yeah.
needed to know, according to you, how effective
Mm-hmm.
has been the Government of India's capacity building programs, information, education, and communication guidebook, which is called IEC. How effective do you think it has been to raise awareness among the people on this lovely Ayushman Bharat Yojana? Do you think it has been effective, that book?
Yeah, I think it has been a very effective tool, and they have been used in a very good way. But I think a lot of other things can also be done besides the book to ensure that the people across India. So for which I think after our esteemed other panelists can talk about it, then I think we can talk about what are the best possible ways to ensure that it penetrates Indian cities across India and how people can use it. I think, but the initial whatever step the government has taken has been pretty good and very effective.
Wonderful. So that tool has been effective. We will discuss other
Yes.
strategies and steps, of course, but that tool, even I personally feel, has been an extremely effective means to spread the news. Thank you, sir.
Sure. Thank you.
Dr. Sinha, would love to know from you, in an era where everything is digital, today everything is getting digital, how do you think we can increase the awareness through effective communication messages so that we can so that the whole aim is to reach more and more eligible beneficiaries? So how do you think we can reach that aim to reach more eligible beneficiaries for Ayushman Bharat Yojana?
Good afternoon, all of you. Very important thing is effective communication for people who are already marginalized, or already in deprived condition. They have a lot of problem related to food, health, other basic amenities. Effective communication in terms of their own need, what they want. Just like if we think about digital communication, we can't say that digital communication is very effective for those people because they don't have a basic amenities also. Basically, Ayushman Bharat Health and Wellness Center scheme is directly focused for the comprehensive primary health care. In comprehensive primary health care, comprehensive in terms of at the time of birth to in life is one stage of the life. Same for any disease, from starting to end state of the disease. Primary care, tertiary care, secondary care, preventive and promotive care. Every step is very important. So we just think about how we develop this strategy for maintain proper communication in terms of key factors.
Yeah. Wonderful. Thank you, sir. Mr. Sharma, would you like to add to this? Because today, as we see, more and more people living even in the rural areas have access to internet service. At least. Hello?
Yeah, I'm listening. I'm listening to you. I'm hinging
Yeah.
on to every word, but I see another screen, so it's right. Yeah.
Okay. So I'll just start with the question again. So basically, I just wanted you, Mr. Sharma, to add on to this, because today, as we see, if we compare to earlier, even rural area has, much more access to internet services. And in the post-COVID world that we're living in now, how effective our communication strategy should be to reach out to more people so that we can reach as many people as possible across this huge and diverse country that we have, about health schemes that are there for their benefit.
First of all, God bless you. You're saying a post-COVID world. I hope it is really.
Yes,
it's so
really hope.
Really. And it's you articulated very well. I've been listening and to the other panelists, and good to see Ajay also. I've interacted with him earlier. It's very nice. The only thing which I would say, see, my personal view here, I'm a journalist. As a journalist, my personal view really doesn't matter here. What matters is what I gather when I talk to people and engage with them. The three things which always matter is actually look at the product. What is the product that we're talking of? Second is look at the target audience that we are trying to address. And the third is in terms of what is the goal that we have. If you look at the product here,
there are the two variants. One is talking of the hospital care, one is talking of the primary care. So where, what is it that is holding back, or where are we making progress when it comes to hospital care? That is getting more hospitals empowered, more hospitals getting enthusiastic about adopting the scheme. What are the lacunae there? What is it? Where do we need fixing there? Second, when it comes to this health and wellness centers, the issue is in the Indian scenario, or globally also anywhere, government products by the government, there can never be a perfect product. It will always be an evolving process. So it's good to say that, this government initiative is lacking or needs improvement. Perhaps for a few, like maybe metro or something, there are very few where we can actually have a perfect product. It will always be evolving. So the best approach in the product, therefore, would be to have a demand pull scenario where we are able to have a demand push, where there is enough groundswell, people are demanding, that gets impacted in the way product is designed. So there on the health and wellness center, my view there would be typically to look in terms of, given the way the health profiles are changing now, you're seeing high prevalence of non-communicable diseases in the country. Cardiac care, there's diabetes, all these are a problem. So if these lifelong associations with the healthcare centers are to be attended to, then primary healthcare centers become very important. And the more the messaging is on Ayushman Bharat and the hospital care, the more we will move away from primary care. So I think the promotion, where we want to focus on, how we want to, that's another thing. And the last, that links to the goal that we have. Broadly, I don't want to extend more time, but broadly around this.
But the goal, sir, needs to encompass all the requirements, right? So according to you, it's a very, very interesting point that you brought up, that it has to be a demand-based product, which depends and should evolve according to the demand and push. Do you think we've reached that stage in the country where it is possible to keep evolving a product, or you think that's the only way forward?
You're asking me?
Yes, sir.
Yeah, no, I think we have to. I mean, there is no such thing as a perfect product really, and especially in a government scenario. So there we need to do a lot. I mean, when you talk to doctors, when you talk to hospitals, there are many who are actually reluctant in terms of, getting impaneled. And the reason is essentially, how much do you pay? Okay. You look in terms of charges. You take a cardiac care procedures. If you're paying maximum 5 lakhs, for example, you have procedures and there is an approval mechanism. If that approval is there and you're not able to pay that much, then how does you will cut corners. You will not be able to provide the best care. And tomorrow, if there is immunotherapy involved, there are different procedures which are involved. So how does one therefore ensure that that segment that we're trying to address is actually getting its objective met in terms of the treatment offered, the clinical outcomes? So if the clinical outcomes are as desired, then it will itself be a demand factor, because then more will opt for it, more will go for it, and more hospitals will come forward. That's it.
Yeah, very interesting point. Actually, something we all must ponder on. And of course, the policymakers and all of us, in fact, need to talk more about it so that, like you said, a better product can come through.
It's not that the government machinery or the officials who are driving this are unaware of this. They probably know. They have been working on this as well. Exactly. I'm just saying, if we keep this in mind and accordingly design the product and make the tweaks there, I think perhaps from what I gather talking to people, that's something which might be much more effective.
Wonderful. And that's the whole aim, to have a product which is as effective as possible. Great. Moving on to Mr. Ajay. In the very first year of the scheme, of the Ayushman Bharat scheme, not many people were aware, in fact, about it. But 3 years down the line today, have we managed to change the narrative to quite an extent? What are your views on that?
I think the numbers says it all. When we talk about the numbers, the way the scheme has been availed, and if you have 90 crores people in India, across India, have availed the benefit during the COVID or like other tertiary care and other care which is required. So I think it talks about the penetration which has been successful. And as we say, it's a huge project. and is going to cater to more so many citizens across India, which is a very, very big population country. So I think over the period of time, it's going to take. But I think the penetration, there have been a lot of challenges, like what Mr. Sharma also talked about. That any such huge a scheme or whatever we talk about, a product which is for the people, it's going to take time. It's not a perfect product. Over the period of time, it's going to evolve. There are going to be changes. Like we talked about the penetration, participation of various, like in India, 70% of the care is taken by the private sector. So that's also a huge thing. How do we ensure that the private sector gets involved into it? So there are a lot of discussions with the Niti Aayog, other people who are involved has been happening, and private sectors are also participating and sharing their point of view, and the discussion is on to ensure that they come out with a product which is successful and which can be benefited by the people across the country.
Yeah.
So that's the overall objective. And I think the penetration over the period of time, so it has improved and is going to improve in the coming years. But there are a lot of things which has to be done to ensure that it gets better.
But seems we are on the right path because the numbers, like you said, are telling us the story.
Yes, the numbers are telling the story that the penetration is there and people are availing it now.
Yeah, because there's a huge jump from the first year to the third year, and God willing, we'll keep getting stronger as the time and the years pass.
Yes, ma'am. Sure. That's objective.
Dr. Sinha, would you agree here? And
sure, madam.
Would you like to add something?
All points. I agree with all points, and one important thing, our health and wellness center, they already penetrated people in terms of their own need. I already discussed 5 minutes before, same thing. What is our need? What is our need, and what are our point of penetration? Both things are going to match.
Okay.
Because previously, people have any minor problem, they just move to district hospital, they just move to community health center, far away. At least 3-4 hours have to take journey, or at least whole day duration for their treatment. But nowadays what happened? Very nearby, within 30 minutes, as concept of health and wellness center, within 30 minutes, availability of healthcare facility, availability of wellness. That's very important thing nowadays. Availability of the wellness, not in terms of yoga exercise, but also health education, in terms of many type of activity, part of activity or itself on activity, many things. So that all are directly affected to people for their need, what they are thinking for healthcare. Just same thing as per their need, and they find that is suitable for them. So acceptance is higher. Now acceptance is more higher. When Ayushman Bharat Yojana started in first year, that time people only thinking, ये हम yoga क्या करेंगे? Because I am belonging to Chhattisgarh, and Chhattisgarh is the place where approx 30% and more than tribal. So that's very new thing. People don't know about that. Before that, they never hear that thing how to do. They never hear about the blood test. What is the blood test? They never hear. They never hear about the glucose level. They never hear about any clinical terms. But now penetration is started. Our people are disbursed for the proper therapeutic intervention, wellness intervention, community health officer posted. ऐसी facilities जो पहले बंद हुआ करती थी, facilities already closed, but now they are open, and they are open automatically. Awareness generation, automatic process created. CHO visited to their place, they find that definitely they given much impact. Their visit in village, their visit in community, that also one of the deep penetration. That visit is not limited to people communication, but also their impact on healthcare, very big impact. People
totally agree, sir. So in fact, now yes, sir, please.
Yes, madam. Yes, madam. I think some network issue.
No problem.
Yes, please, ma'am.
Yeah, so I just wanted quickly to know from you also that all this details of the schemes, like for example, the diseases that are covered under the scheme and the family cap and other nitty-gritty details of the scheme. You think now there is more awareness among people? People know more about these? Has the communication been effective about that to pass on this message down the line?
Yes, madam. In my previous 5 minutes before talk, I already specified that as per pupil need. And now 2 minutes before, same point I mentioned. What happened in Ayushman Bharat Health and Wellness Center? Population enumeration, community-based assessment checklist that filled by Mitanin, Asha, MPW. MPW are supporting for this activity. That given deep penetration impact.
Yes.
Someone reach their home and talk about their health and questioning about their health, what they are thinking, what they are doing, what have to do. That all questions become a point of penetration. That point of penetration, that is little bit awareness. If I am saying many times to people, oh, how is your health, or your glucose level is high, that is another. But I go to their home and sit with them and communicate with them in their own language, their own terms. अगर जमीन में बैठी है पर्टिकुलर लेडी, तो उसके बाजू में जमीन में मितानिन आशाएं होती, बाजू में जाके बैठती.
बिल्कुल.
तो जो एक सिंबल क्रिएशन होता है, जो आपस में जो सिंबल क्रिएशन होता है, गुडविल क्रिएशन होता है, एक फेथ डेवलप होता है, ऑटोमेटिकली वहां से फेथ डेवलप होना स्टार्ट होता है. They started good conversation, family conversation, community conversation, health related conversation, many type of conversation. That conversation become a good shot for the healthcare support.
Wonderful.
Yes.
Mr. Sharma, just your opinion again on, should the government focus on joining hands with more foundations and NGOs to increase the awareness among people? Do you think that will be effective? And also, in the next 3 years, according to you, what communication strategies should be adopted both by the government and the non-state actors to turn Ayushman Bharat into a Jan Andolan?
Great question, actually, with no immediate answers as I can see, but it's something which we will also have to learn all through. But definitely, I think just the focus on the product really, which will be very important to drive the demand here, which I said also earlier. Now, for example, this demand side articulation that I've been mentioning is essentially it's important in the context of the disease profile that we're having. And also when you talked of getting the private sector, getting NGOs and others involved, it depends on also what is it that we're trying to address. When we talk of, let's say, if it's a tertiary care, then what kind of care are we giving, and what is holding back, let's say, whoever is not in panel or joining, what is it that is holding back? There was recently a Niti Aayog report, if you remember, which talked of the missing middle. The missing middle when in the context of Ayushman Bharat that they mentioned. So how do we address the missing middle gap, particularly that got accentuated with COVID? So how is that? And because once we address those elements, the demand will obviously pick up. And this is an area where there is enough awareness in terms of people talk about it, but the benefit is when actually those who know and talk actually get to use.
Yeah.
And based on that, it has a ripple effect. So my point is just what I said in the beginning also, that if you just focus on the target audience and trying to address, fine-tune the product accordingly, I think much of the problem will be solved.
And you think we are on the path to that?
We are always on a path to improvement, I would imagine. Otherwise, it's a degrading, it's a decaying society if we don't try and progress and improve on. And I'm sure if you talk to any of the officials in Ayushman Bharat, we all would want to improve and make things better. I'm sure we are on trying to do much better. And if numbers have increased, it's only an indication that perhaps we are on the right path. But the problem is this what we need? I mean, given the India scale and size and deeper penetrations, you see in the primary care center, when we go to, you see from a primary care center, the first point is essentially you need doctors there, we need nurses there, we need essential medicines available, we need a jeep with the fuel, and all this. As was pointed out earlier, Dr. Narendra also said, the system jo chalta hai, which is actually, which is working and functioning system from all aspects really, and all the essential medicines available, all of that. So it is a challenge. And if you look in terms of the remote locations which are there that we have sometimes, you look at the vaccination also, the vaccination process, there was, I don't know the current numbers now, but when we touched the 1 billion, there was still about 25% of the population which had not even got a single shot. We had to reach out to them. So in the immunization program for polio, which you said, we had challenges. We had to reach out to them. There were issues of anti-vaxxers there as well. There were problems that had to be countered. We had to do it, and we had to develop the cadre and do accordingly. So one is trying to fine tune from the way we approach it. The other approach is, in this case now, since it is known, it's better to kind of create the demand which will force product improvement.
Yes, great. Mr. Ajay, I would really like your opinion on this also, or the question that I asked him about the importance of involving the NGOs, and also, in your opinion, the role of non-state actors. Just how important do you think that could be, or that could prove, how much additional benefit can that add to the success of this scheme? Do you think both will work or one will work? And if yes, how should we go about these?
First of all, I'd like to say, for any scheme to become successful, most important is what is the customer feedback.
Yes.
Somebody's availed a scheme, and the word of mouth, the way it spreads, is the best thing. Basically, if somebody's availing and he gets the right kind of treatment, like what Mr. Sharma also talked about, essential requirement for success, where you have to make sure the doctors are there, the paramedics are there, the nurses are there, the other required things are available to make a scheme successful. All this is essentially required. And the most important part is by the word of mouth. If I get a good treatment today, if I'm availing the scheme, so from my word of mouth, there are going to be 10 people who will know that I'm a happy and a satisfied customer who went and availed this benefit. So that is extremely important. So to highlight the benefit, what the scheme is going to be all about. And like you talked about the other things, like involving the other NGOs, what can be done. So there are a few, I think there are 2-3 points which came to my mind, which I've written also. So most important is now the digital world is picking up. So like Dr. Sina also pointed out this, I mean, in deep down other villages, or maybe the penetration of internet and other things are not there, but most of the people, if you see across, have a mobile phone now, and they're availing the WhatsApp or other kind of facility which are there. And the message circulation, like the news travels very fast now compared to what it was maybe a few years down the line, where you used to take 2 to 3 days to know what has happened. But today it's instant. And it spreads like a wildfire. So we have to use those kind of mediums. So like I was talking about WhatsApp video. So if you actually see, like if you use the video in the right way, and you can, that's going to really benefit and make sure that people are aware about the scheme and everywhere. And it has to be in the vernacular regional languages also. If you want to have that, it has to be a clusterized kind of a customized communication. So it has to be according to the cluster, and you have to customize the communication according to the vernacular thing. So you should have your vernacular language there. So WhatsApp video, that's going to help really penetrate the video and basically about the scheme, so people will be more aware. Then the set of trade fair, now it's the pandemic, so things are stabilizing now, and most of the, I think hopefully we're over the pandemic now, and if like we're talking about the vaccination, like Mr. Sharma said, so more than 100 crore people are vaccinated, and the second dose has also been administered, a lot of them. So that is also helping people, like if they're getting, because I'm in healthcare, so we get the data on that. Like if people are getting infected with COVID who are vaccinated, or vaccinated with both the vaccine, this very mild form of COVID is coming to us, like cough, cold, and other things. So that is the thing which people have to understand. So if you see like what happened during COVID, so after a few months, everybody's aware that we have to have a social distancing, or we have to wear a mask, or we don't have to do this and that. So that is the kind of penetration which happened, and I think across India, everybody was aware what has to be done. Initial days, there were some issues, like people were not aware what the protocol and how it has to be managed. But later on, everybody's aware that how it has to be done, and it took maybe 3 to 4 months because they saw the intensity and the gravity of the situation. So something which is going to be benefit. So it depends how it's portrayed and how it's projected. And you're talking about other so set of trade fair, organize mega camps. So all these kind of activities can be done where to promote the product and to talk about the various benefits the scheme has for them. So this can be done so people are where they can connect. So Nukkad Nataks are there. Other things, a lot of the Anganwadi you talked about, the different schemes are there, like Saksham Yuva scheme is there in Haryana. Then the local political party, when they have this, so they can always talk about this scheme, that this is something like, if you talk about the political and the kind of way the EC conducts the election in India. So it goes to deep down every root of the country, and they come and give their votes. So why not? This can be also awareness kind of a thing where they can penetrate and talk about the people and give them the benefit for the scheme as for them. So I think a lot of things are there. Tie up with a big corporate like IFCO and all are there. So they have the presence across India. They're connecting and touching each and every part of the country and the kind of segment what we're looking at. So that is also important. If you connect with them, ask them to help and drive. So that's also going to be a major penetrator, and it's going to benefit the scheme in a big way. And NGOs for sure.
Yeah, these are all extremely important points, and I think they'll be all very, very effective. I'm sure a lot of them are being already put into practice, but further push to them. As it is becoming extremely clear from this conversation, communication is really the key to make this wonderful scheme, which is a great scheme, to become accessible to everybody. Because only when people know about it will they, avail of it, and then its whole purpose will be met. Mr. Sharma, would you like to add a couple more points if something comes to your mind about better communication about the scheme, how it can be done?
I think not much really. I mean, what we have said is, I think the manner in which it is. I mean, you look in terms of there's always room for improvement. I mean, if we put more case studies in mind, we talk about who has benefited, what has been the extent, how has been the engagement in terms of the costing, for example. See, costing again is very important. There's lack of clarity in terms of how this works out. How is the approval mechanism? How is, for example, if you you referred to the cancer care earlier. So how is the cost breakup there? How does it matter, and how is it that given the limited funds that are there, how is it making a difference? I think I think those are more problems that that we need to attend to, and if that is there, and I think then the proof of the pudding, as they say, is ultimately much depends on how the end product is delivered. That in itself will be a big driver, whether it's from the health and wellness centers or from tertiary care. I think
the word of mouth that you were mentioning earlier, right?
My only point is that I don't hear much on the health and wellness centers, which in today's context, given the disease profile that is there, we need to propagate more on the health and wellness front, because the more we talk of tertiary care, I've said this earlier also, the more we talk of tertiary care and the hospital environment, we will actually move away from primary, which is not a good thing. I mean, we need enough focus on primary, and we need to build on that and promote that. So if focus can be to fine tune that and improve on that, I think it will be much more endurable and much more enduring.
Yes, absolutely, totally agree in that. Dr. Sinha, you've been talking a lot about the ground level work and the importance of it, and that resonates very well with me, and I think with everyone who's listening, because digital is one way of communication. And like what you mentioned, going down to the ground level and actually reaching out to the people who can and will benefit from the scheme will get us far more dividend. And also there are regional differences. Across every state, I'm sure there are different kind of challenges. So in your state, I would really love to know or hear from you any interesting case study or any effective method that has worked wonders for this scheme. Would you like to share something?
Surely, madam. Basically, in terms of healthcare provision, may I audible?
Yes, sir.
I think there is some network issues continues up and down.
We can hear you. Provision
of health is one major concern. In case studies, I have a few our practical experience from Bastar region. Bastar, that well-known area, that is a left-wing affected area. Our healthcare delivery, what they are doing, they are, because people are not aware about their need. Also, they're not aware about their need. What they are needful, they don't know, because they have a literacy level 0.
Yeah.
And second, understanding level also 0. So they staying long time, lifelong in tribal only. They don't know about basic food also. They just carrying some food material from forest and they consume that for their food related need. But now penetration started. Deep coverage started.
Yes.
Government people are going to reach on their place. Our health workers are going to reach their place. Our ANMs, MPW, they are going to their place, and village are identified. New village are identified as step by step. New village are going to identify, and then our health scheme also going to reach on the place. Health schemes are going on that place. They have a Aadhaar number, unique identity number. Aadhaar started health card. Now we started registration in health and wellness center. What going on the field? Health and wellness center is one place, and 10 kilometers away their village or the new identified village or new identified clusters. On those clusters, our health people are going to reach by walk 10, 12 kilometers, by river, no roads. That's many times media also covered that. No roads. So what is our communication strategy there? What we did, we already covered related people or their relative. We already covered their relative who already connected with them. Provide deep sensation about health related need, what are the health related need of those people. Just like immunization coverage, we already covered big immunization in Chhattisgarh. Also, you hear Raigad district is one of the good district of Chhattisgarh who already covered 100% immunization. That is Raigad, but we talk about Bastar and Korea, and Bastar have a 6 to 7 district, Korea, that are mostly Jashpur, that are a tribal belt. So what we are doing there, we just approaching local people. Mitanin are already there. Mitanin means Asha are already there. But local small self-help group, they are supporting people. Local people, conversation mode, new strategy for conversation, we started there. Their own language, their own practice, what they are thinking, what they are assuming. So we utilize their thinking and their assumption for aware them. And same strategy, we adapted whole state. That was the baseline strategy. And now we are going to community-based assessment. We are going to fill community-based assessment checklist from those people also. We are going to population enumeration for those people also. Digital entry of record in NCD portal, in Health and Wellness Center portal, SWC portal, NCD application. We have a digital record of people who are staying in the deep forest also. Okay. So that possible due to the digitalization. If we are saying to any staff to keep in paper and just save it for long duration, it's not possible. So this digitalization is directly supported to our motto for comprehensive primary healthcare. Also, we have 7 basic things and 8 proper criteria. In 8 proper criteria of Health and Wellness Center operational, infrastructure, availability of infrastructure. In infrastructure, we are creating a new way. People are already seen that is sub-center, that is a PSC. I am saying about normal place, not for tribal. in tribal health and wellness center is a big like a vardhan. They're facing like a vardhan. नई चीज आई है, कुछ ऐसी चीज आई है जो चमकीली बिल्डिंग दिखती है, गोल गोल कुछ डिजाइन दिखता है. That is my personal experience in field. When I visited field visit, my personal experience आप health and wellness center को जानते हैं? मैं उनकी लैंग्वेज में बताना चाहूंगा मैडम. हाँ साहब हमन जाना था, उनकी लैंग्वेज में बताना चाहूंगा. दैट इज सच वेरी लैंग्वेज. हाँ साहब हमन जाना था, पहली अस्पताल असन रही से बंद रहा है, अब गोल 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 गोला लगे रहते, और वहां एक जन डॉक्टर आए, मतलब दैट इज CHO. दे आर सेइंग ऑन देयर ओन लैंग्वेज, दैट इज CHO. पहली साहब वो मैडम वहां रहती होती दौड़त रहा है, अब तो कोई न कोई रहते अस्पताल में मिल जाते हैं, मान ला सूजी पानी सबके हो जाते. That is on their language, means they are understanding. They are understanding better that facilities, that all facilities are for their own. उनका है, उनके लिए है वो. पहले और अब हम ये बात करते हैं, पहले और अब में क्या डिफरेंस था. What was previous and what is now. So उनका एक ही जवाब होता है. What they are saying, that's very good in now stage, but abhi bhi, in my view, not a in my view, I think that we also move more beyond that. In digitalization, we need to cover 100% population. We are working for that. Definitely, we are much working for that. Our ground team is working hard for same. Digital ID, NDH, National Digital Health Mission, that is working for digital ID. NCD screening, Health and Wellness Center is working for NCD screening. I already told 8 components for healthcare operational as per Government of India criteria: infrastructure, HR, training, drug, diagnostic, community outreach, and NCD screening. NCD screening, one of them. If we are saying digitalization, we have a one criteria of operationalization is IT. Availability of IT equipment, availability of proper training. If any health and wellness center is functional in condition of total 8 criteria, if fulfilled, that is operational. If 8 criteria is not fulfilled, that is non-operational health and wellness center. That's very good thing. So our movement for digitalization and our movement for far away to achieve CPSC, comprehensive primary health care, really that is a very nice movement. One more point related to role of NGO and involvement of NGO and community-based organization. I want to focus on them. NGO and CBO are the pillar. As my experience, NGO and CBO, community-based organization and non-government organization, they are pillars. If want to penetrate any village, directly go to village. If anyone go to directly village, that may be possible due to Mitanin, means Asha. You have a good communication with people because of Asha. But if you want to know mass movement, if you want to mass penetration, so basically CBO members are coming from them. VHSNC, Village Health and Sanitation Nutrition Committee, just Health and Wellness Center, Jan Arogya Samiti. There is a small group prepared by and supported by the government. VHSNC, they have a good structure. Jan Arogya Samiti, that is a management structure for health and wellness center, sub health center. So who's supporting them? Small CBOs, Mahila Mandal, members from Mahila Mandal, they already member of Jan Arogya Samiti. They are involving in VHSNC. Lot of Mahila Samiti, Mahila Mandal, self-help group, they are supporting. They are providing deep penetration to community. They are providing awareness. Why? They are already part of community. If someone goes to community, they just clear one message. So that message they send to someone. That's not mean that for one person only.
Yeah.
That have a big umbrella for awareness. Start एक जगह से हो रहा है, लेकिन उसके साथ जो चेन जुड़ी हुई है, वो चेन काफी लंबी होती है. That chain will very big chain. तो ये जो communication strategy है, that's very important in nowadays. In the starting of health and wellness center, very less people know about what is health and wellness center. यहाँ पे होता क्या है, इलाज ही तो होता है. लेकिन जब इम्पैक्ट उन्होंने देखा, नहीं इलाज तो होता है लेकिन इलाज इस तरीके से होता है कि अब तो टेलीमेडिसिन से जिला अस्पताल का मेडिकल कॉलेज का डॉक्टर हमसे जुड़ता है. अब ये अंतर मिलता है. अरे सर हम तो सोचते थे कि बस इलाज होता है, यहाँ जो बैठते हैं मैडम सर वो बस दवाई पानी देके छोड़ देते हैं, हम ऐसा होगा सोचते थे. लेकिन जब प्रैक्टिकली स्टार्ट हुआ तो सर लगता है नहीं, यहाँ आ गए मतलब आपने पूरी दुनिया देख ली. ऐसा जवाब हमको फील्ड में मिला.
Wonderful.
Few patient already get good benefit, at least for cancer treatment also. They got communication in telemedicine, e-Sanjeevani. They got good communication, and after their communication, they just visited and taken treatment and back to their place. तो कहीं ना कहीं एक अच्छा पॉइंट जुड़ा हुआ है इन सब चीजों में. कहीं ना कहीं पॉजिटिविटी दिख रही है. Something means I want to say something is going very good beyond to normal. And
fingers crossed. I hope ये ऐसे ही चलता रहे, and जैसे आपने कहा chain बढ़ती जा रही है. I hope the chain keeps continuing to spread like wildfire across the country. Mr. Sharma would really, I mean, these are some wonderful pointers from Chhattisgarh, but that's like one state in our country. Does anything else come to your mind about any good work happening in any other part of the country? If you can, maybe share one or two case studies, if you can recall.
There are. If you look in terms of the diversity in India, there are states, whether it is Himachal or whether you take, Kerala, whether you take Mizoram, there are states who actually their health budgets have been more than some of the biggest states in India. So that varies. It's a huge difference. It's not a uniform entity. In fact, some have multiple times of the national average in terms of health spend. So health budgets of various states. So based on that, there has been a difference. I mean, each is not. You look at Niti Aayog reports and others also, which point out how the state-wise difference is there, which is pointing out in the indicators also that we have. You look at mortality and all of that, or if you look at National Health Survey data also, based on different states, it's visible in terms of those who are spending more, the way we get impact. So that of course is always there. The point which was pointed out by Dr. Sinha also, yes, I think there is movement ahead. But are we happy with what we're doing? I mean, there's a question of always wanting to do better, I would imagine.
Yes.
That will be the earnest hope, isn't it? And I think we have a long way to go ahead in this. And if you talk in terms of as journalists, when we talk to whether it's the hospitals or whether whether the corporates actually say that they are officially, whether they comment or not, I mean, some of them if you speak to, there is a lot of hesitation when it comes to getting impaneled and all of that. They have this problem, and it's essentially boils down to the pricing in terms of how much is the realization. And it's not as if that there has to be a ways in which one deals with it. It's not so as to encourage profiteering by a private entity, but there are mechanisms. I mean, like the Niti Aayog report talked of the missing middle. So is there a way in which people can actually, there is a top-up option available on the primary care, so that in case of, severe and, ailments where a larger expense is required, how does one deal with that? Or there are options where in the light of pandemic, really, people, the common man who's, the salaried, who has 50, 60,000 income a month, can he or she afford a 4 or 5 days of ICU care? So what is the option? They can't. There is Ayushman Bharat cannot help. The normal afford of out of pocket payment will not help. Insurance may not come to their help at that time. So can an Ayushman Bharat and a top up reach out to that audience? Can something be done about it? If things like this can imaginatively be looked and addressed, I'm sure there will be more demand. So again, going back to the same point of trying to define ourselves.
Yes, I think, yes, the whole point is to keep learning and keep moving on and keep building a better and better product. So because ours is a very huge and a diverse and a complex country with the population increasing, every second. So the challenges also keep adding up. And to top that, we have regional differences, and different strategies are required for different regions of the country. And what might work, for example, in Chhattisgarh might definitely not work in, say, Rajasthan or maybe northeastern states. So a process which needs to keep evolving at a pace faster than even possible, I feel, is the only way to make this extremely successful. I'm just thinking here, Dr. Ajay, I began the whole, and everybody would actually begin with by talking about the successful polio campaign, which obviously took many, many years, 2 decades, in fact, to become so hugely successful. But according to you, does any point come to your mind, or any lesson from that time, or any successful strategy that was employed for that campaign, which you think might be viable even today in this internet-led era?
I think communicate. And the message, that's the key to ensure that it's of a success. But I think a lot of brilliant points are shared by Mr. Sharma and by Narendra ji or Dr. Narendra also. But I think what the government has done, I think what the initiatives they are taking as well, because the communication also evolves year by year and everything. You can't have a set of if this is going to work, what you talked about, diversified India and different clusters. So the strategy has to be different. And you have to ensure that you are providing the right information, people to get aware. But the steps taken by government, NHA has done a survey across India where they have conducted and seen that each other what's the kind of penetration they had. They had interviewed various households to get the feedback on the stuff. So awareness level in some parts of the country was pretty high. In Bihar, maybe it was pretty low compared to Tamil Nadu. I think that people are getting aware. So the strategy and the digital penetration, what we have as of now, like you could listen to the Prime Minister from any part of the country, anywhere. You're sitting on a phone also, which was not possible earlier. Earlier, we had used Amitabh Bachchan, other people like stalwarts from the industry who were like the voice of the nation kind of a thing, and they could talk about something and people could connect with them. So that's a strategy which anyway has to go on, and people have to come forward and participate and ensure that they are talking about the scheme and people are getting aware about it. But the digital penetration is definitely going to help. And I think the steps taken by the government towards the survey, what they're conducting, the kind of feedback what they're getting, and the kind of strategy what they customize according to that is going to be very helpful in reaching out to the audience. And also, like, it's my personal views. I'm not talking from the Fortis behalf as of now. But I think the privatization, and they have to look at the scheme about everything, how to ensure that more and more private players participate. What's going to be a lot of discussion are going around that. And so how do we ensure that to make it more viable for the players to come and participate? If 70% of the population is being taken care by the private healthcare, so they play a huge role to make this a success. So that's going to be the key to make it a success, because 30% taking care of the complete population is an impossible thing to do, and an impossible expectation.
Yes, makes sense. For me, I mean, as a layperson and as somebody who just writes on health, I feel what Dr. Sinha mentioned, and that really strikes a chord with me, about taking pride in the fact that this scheme is theirs and it is for their benefit. If we can reach that level in the country, the way, frankly, Pulse Polio scheme did, it became our program. It became something every countryman became proud of, to say that such a huge country, we managed to become, polio free. So if somehow that kind of effective communication, which touches the heart of the people and touches a chord with them, to make it feel that Ayushman Bharat is their scheme, if something like that clicks, I think that probably would be the key to take it to the next huge level of mass awareness.
Sorry to interrupt, but we talk about polio, but look at the 100 crore vaccination which has been done.
100%.
So we were talking about that's going to be impossible. Everybody said it's not possible to vaccinate 100 people in 8 months or 10 months period of time. But this has been done. So that's a success. That's what I'm saying. It's possible to implement and make 100%. Sure the people avail it. So yes. That's the potential of the country and how we can communicate and make sure the people are aware about it. So it will be availed for sure.
Yes. So let's hope that happens soon, so that this can it doesn't take 20 years like it did for polio, and we can do it faster for this scheme and benefit as many people as possible. We're on the right path, but as Mr. Sharma also mentioned, have to keep, introspecting and keep improving the product. We have time only now for closing remarks. So maybe we can begin with Mr. Sharma. If you could just give in brief couple of closing remarks, and we'll move to the other panelists and wrap up the program then.
Nothing much really. I mean, we've kind of covered enough ground really. And I just the same thing that, let's keep on fine-tuning better, communicating making suitable changes so that, given the disease profile that we are seeing in the country, if we can have our systems, whether it is then the primary care or a tertiary care, the solutions are provided, which in turn will drive more demand. And the more we are able to have a situation where we can drive more demand, the product will definitely get fine-tuned, because that will be the demand. So,
so communication is the key for driving the demand, clearly. Right communication.
Yeah, I think once the problem is addressed, the demand will be there. And if the demand is there, that will itself, as I'm repeating again, it will fine tune the product, and that in itself will be the driver. I mean, if you need the more people to take it, it's not that people are not aware of what is happening on Ayushman Bharat. No, the question is really to make a difference with it, make it as wide as you said. If you have to go to a goal of universal health coverage, then that is the way forward. We need more people covered, and making a difference to them. That's a journey where there's always distance to cover. So,
great. Dr. Sinha, your closing remarks, please.
Muted.
Yeah, sir. You are on mute, sir.
Yes, madam.
Yeah.
Sharma sir told very basic and logical point. Really very appreciating point, sir. Few things is there. Demand from ground and availability of the services, resource, two things. So demand generation is very important now. Demand, when demand should generated, means awareness of people and their deep sensation regarding to services or need. So I already mentioned previously, need is very important. They should much aware about their need. They should much aware about need-based their demand, and demand should be fulfilled by our side, from government side. That is very important. Second point is there in effective communication. We already communicated much thing. And a lot of topic cover, really very nice topic covered. Every communication is very point to point and keen observation. So for journey of Ayushman Bharat, that is a very big journey, not limited to today. If we are going to screen people, we have to provide proper care, treatment and support. Support not limited to one day, support limited lifelong. Care not limited to 1 day, 1 year or 2 years. That should be lifelong. Every point is lifelong, and we are saying comprehensive. If we are saying comprehensive, means our approach is in big umbrella. We have a very big umbrella. We should cover too. Tomorrow, Universal Health Coverage Day. That is logo also one of the umbrella. So that umbrella and coverage of umbrella and recognition, that's very important.
Wonderful, thank you. Mr. Your comments, and then we'll wrap up the program.
We've talked about everything. I think what comes to my mind to make this a success, I think we have to ensure that whatever the services are being provided across have to be of the quality and according to the requirement, maybe the tertiary care or critical care, whatever we're talking about. So that's the kind of care should be provided. And this is what we talk about, the umbrella about this, complete umbrella about the scheme. So that has to be important. And that has to be in place, and it has to be in sync. And so I think that will make it a success, and that's the need of the hour for the country, and such a huge country where the government has also increased the health budget. So I think they should focus more on it and ensure that the right kind of treatment is offered at the right cost.
Wonderful. I think this has been an extremely illuminating discussion, and we've all benefited, but everyone who's listening would have got a lot of pointers out of this. Thank you so much, Dr. Sinha, Mr. Sharma, Mr. Ajay. It has opened up my eyes, and I'm sure a lot of people who are associated with the scheme or not been associated with the scheme would have benefited a lot by listening to this discussion. And most importantly, this discussion has made me very hopeful about the future of the healthcare in the country, because it seems the solutions are there and we are on our way to reach them sooner or later, hoping for sooner, of course, for the benefit of our country. But thank you again very much. Thank you for joining us. And I think this has been a good discussion. Hoping to do it again sometime when we are at the next milestone of the scheme. Thank you.
Thank you
so much.